So, very happy morning to you all. It's a great pleasure in inviting you all on behalf of Department of Pediatric and Preventive Dentistry, KSR Institute of Dental Science and Research, Tiruchengood, Tamil Nadu, for our CDE program, the Open Secret Pediatric Orthodontics. I welcome our beloved chairman, line Dr. K.S. Rangasamy, and our vice chairman, Mr. R. Srinivasan, for this program in absentia. I cordially invite our dynamic principal, Dr. Sharath Ashokan, and we are glad that we are conducting this CDE program under the aegis of Indian Society of Pediatric and Periodontic and Preventive Dentistry. And I would like to share the thought of naming this program again as the Open Secret. So it is an oxymoron word, which means something that is supposed to be a secret, but generally known by all. So pediatric orthodontics, though a familiar topic, there are still some gray areas or some secrets which are yet to be explored. And in recent days, myofunctional therapy is offering a viable alternative to traditional orthodontics, and even the treatment of choice for many parents for their children. So it is a need of the hour, and so we thought of this topic. And today we have two eminent speakers who have come here to share their knowledge and clinical experiences in bringing out or creating a beautiful smiles in children in their own style. So I hearty welcome to Dr. Jeevarathan and Dr. Meera Ramaswamy, and we are very happy to have you all with us, and thank you for accepting our invitation. Now, it's my great pleasure to welcome all the pediatric dental fraternities, senior faculty members, other department fraternities, academicians, clinicians, and my dear students all around the country. And we have received an overwhelming response of registration, more than 380 participants, and we were actually forced to close the registration after extending for another few hours. And we have 43% registrations from faculty, 32% from postgraduates, and 19% of registrations were from private practitioners. And we are very happy to have around a few registrations, 5% from even undergraduate students were also interested in attending this program. So my heartfelt welcome to one and all present here. So now it's time to unveil the secrets of pediatric orthodontics, and I'm wishing you all a happy learning. Thank you. So I request Dr. Vishnu Raj to introduce the first speaker of this team.
Good morning, everyone. Myself, Dr. Vishnu Raj, Senior Lecturer, Department of Pediatric and Preventive Dentistry, KSR Institute of Dental Science and Research, take a privilege to introduce the speaker, Dr. Meera Ramaswamy. She has completed her BS and MDS in the Department of Orthodontics and Dentation Orthopedics from Meenakshi Ammal Dental College in the year 2013. She has presented various papers in different conferences and conventions, and also delivered guest lectures in various topics. She is an active member of Indian Orthodontic Society, Indian Academy of Forensic Odontology, and Indian Academy of Aesthetic and Cosmetic Dentistry. She has an ample publication in various indexed international journals. She is also an editor for orthodontic section in the textbook of Pediatric Dentistry by Dr. M.S. Muthu, a versatile singer and a classical dancer. We were happy to inform, we have you present with us, ma'am. We welcome you, ma'am. Over to you, ma'am.
Thank you so much, Vishnu, for that introduction. And thank you, Sharath sir and the team for this opportunity. First of all, I want to say my greetings to all my teachers who are on this platform today. Jeeva sir, Sharath sir, Shivakumar sir, and so many more. I can see, I think Farzan sir also there. So with all these mentors and teachers is what that my journey had started and continued further. They were my inspiration from Meenakshi. So first of all, good morning to all the participants here. I can't see everyone's name, so I don't know if there are any anyone who's familiar to me, a hello to you all as well. And yes, so looking forward. So can I start with my presentation? Let me screen share now. And can you all see my screen? I think it should.
Yes, yes.
Okay, okay, sir. Thank you. So I'm going to cover this topic very briefly in the morning session. We're going to discuss about diagnosis, how we diagnose a case. So I'm trying to make it really crisp, as in when a patient walks in, what exactly you look for, and when you identify what you're looking for, and then how you proceed with it. So the morning session is pretty much a brief of the entire pediatric orthodontics in a gist, to summarize. And in the afternoon session, I'm going to cover like a roadmap to myofunctional therapy, in which I will have a few of these slides overlapping as well. So if I'm not focusing on a particular slide in the morning session, is because I'm going to cover it in detail in the second session. But if you have any doubts, we could definitely discuss this at the end of the lecture, because it's very, very difficult to concise the entire pediatric orthodontics in one small session, but I'm trying my best to do so. So a very good morning to one and all once again. My slide isn't working. 1 second, sir. I'm not able to. Okay. So I think with COVID was like a blessing in disguise. All of us found our hobbies, our passion, our whatever we wanted to do. So like a lot of us, I know, got into cooking, workouts, some people just binge watched Netflix or any other OTT platform. So we all figured what we wanted to do, but that was all our perception at the beginning of COVID, right? Like when the lockdown was announced, we were like, okay, we'll do this, we'll do that, we'll do this. And, we have so much of time. But the true reality is the last picture that's on the slide, like the ground reality. At least the mothers and the fathers in the platform will understand that we ended up doing this and none of the above things, like in a bigger scale. So that's what happened, at least in the other side of the world, where we hardly have any help. So perception is something and reality is something. So I think this presentation is going to highlight this very single point. And we had this discussion even 3-4 days back with my husband. I was having this discussion, how what we perceive and what actually the ground reality is so way different in most of the scenarios. And it applies the same in pediatric orthodontics, because a lot of times we perceive pediatric orthodontics as something else, but then the ground reality as to what we can implement in a patient because of various factors. I'm not saying just because of knowledge or skill, but then there are so many other factors, at the age at which the patient comes in, the financial situation of the patient, the actual malocclusion in that particular patient. So everything is so varied and different, So I always feel pediatric orthodontics itself has this huge scope of being a super specialty by its own. Like we have super specialty in medicine, right? Like we have pediatric neurology, pediatric nephrology. So this topic, not just because I'm an orthodontist, but I'm actually a passionate pediatric orthodontist, I should say, because that's how much I love pedo. So this topic has such a huge potential to be a super specialty on its own. And why I'm saying this is the essence of today's topic, is because that the vast, like for example, let's start, say it starts right from birth molding, and it goes into clefts and cleft deformities, and then into primary, permanent, mixed permanent dentation, way up to 19 years. So there is a huge lacunae also in this domain, because there's not enough research. There has been research that's been happening, but then there is not enough research in specific areas in pediatric orthodontics. So for any postgraduates in the platform, or any interns or undergraduates in the platform, this is one area that you could really, really focus on to, specialize and super specialize. And it would be a very, very niche platform, especially a few topics inside this would be a very niche platform for you to work on. So going into the topic, I'm going to try to summarize this into primary, mixed, and permanent dentition. And under these, we're going to see what are the issues we face and how we address it. So in primary dentition, it's pretty much what we can do in terms of orthodontics would be more of, anticipatory guidance or counseling or space maintenance therapy. There's very little scope to actually address to anything at this stage, only because even if you read Graeber Van Isdal, that's what they would say, that any form of habits that would cause any malocclusion at this stage would be automatically masked by growth. So way up to 5 years. Of course, now the recent studies have shown you could even go up to 5.5, 6 years. But then, sorry, hello. So someone's trying to say something.
No, don't bother. Somebody.
Oh, okay.
Shooting like that.
Okay, so so way up to 6 years is what we consider now. But again, to go back to textbooks, we would say 5 years. So we can consider this normal, and then we could wait until 5, 6 to reevaluate the patient and to see if there's something that has to be done. Only 1 or 2 situations, like say a patient already has a very severe anterior crossbite in a primary dentition, that that you're looking towards a very severe class 3 in mixed dentition. And we're not going to do anything at this stage. So that's why I don't have anything under primary dentition, just anticipatory guidance and space maintenance. But it's a very, very good phase to actually look at the patient and identify or anticipate, or even tell the patient what they can expect in the next couple of years. Like the example I just gave, a very severe class 3, an anterior crossbite can be picked up at that age. So you can tell the patient, it will be ideal if I can see him every 6 months to follow up. At 5.5, 6 would be an ideal time. We'll see all that, what's an ideal time to treat it. But, it's a good way to motivate the patient and keep them informed that they can keep coming back to you for checkups, and you can start the treatment at the right time. Now, in pediatric orthodontics, the key is when we start treatment. The age factor is the most critical factor of all the other variables. So if we can tap the patient at the right time, we can make full use of that growth spurt and provide the right treatment plan for the patient and get the best out of it. So it would be very, very important to actually evaluate the patient in primary dentition for this sake. Going on to mixed dentition, this is the most crucial phase in pediatric orthodontics, where you can do a lot of things which can prevent say sometimes even braces in permanent dentition. It can prevent surgery in permanent dentition, orthodontic surgery in permanent dentition. So this is a very crucial phase. So I always feel when we miss the patient in this phase, that's when they go into corrective orthodontics and surgical orthodontics further on. Of course, there are a lot of patients, like say 80% of them, even though you do something in phase 1, they will need a phase 2 later on. But it will be a milder phase 2 compared to, you can get away without extractions in phase 2. You can get away without any minor surgical procedure in phase 2. So we are actually doing a lot of good to the patient by acting in this mixed dentition phase with the right treatment plan at the right age to prevent something further. So I always feel in my personal opinion, that this is actually a preventive approach, though we are actually doing an a treatment like an invasive procedure. I won't call it invasive, but then in the West, even this is invasive. So even though we are doing that, it is still a preventive protocol for something that you want to prevent in the permanent dentition. So it's a very, very important piece. So in this, you'll have to address to habits, you do habit correction, we have to address to space maintenance and space regaining in case of lost space, if we have lost some space. And then the growth modulation and orthopedic treatment. That's our focus for today's lecture. We are not covering most of the other things which you'll find in all your pedo textbooks: serial extractions, impacted teeth, supernumerary teeth, cross bites. So all of these, you address it in the mixed dentition phase. And then comes the permanent dentition phase, where you just do corrective orthodontics, which is either braces or your aligners. And then you do your surgical orthodontics where it is required. So going on to, so we have these malocclusions classified as class 1, class 2, and class 3. Now, all of us are aware of what is class 1 dentally, what is class 2 dentally, and class 3 dentally. Now, I'm not going into the dental classifications, which you can just read out of the textbooks. But what I want to focus today is the skeletal class 1, class 2, class 3 relationships, how you can clinically identify this, and then, subject the patient to investigations, and then further take it further on. So when we say class 1, class 2, and class 3, we do have skeletal and dental component. As I said, let's leave the dental component for now. So with skeletal component, what are the possibilities and what are the treatment options that are available? Now, even class 1, you have class 1 skeletal, where you have either a bimax protrusion, where both the upper alveolus and the lower alveolus is protruded. So we call this bimaxillary protrusion. Usually when what we do for a bimax is, most of the time they come to us when they are adults, and then we do an all-four extraction. We could do, like, if it is a very severe bimax, you can do like a surgical correction, an orthodontic surgery. You extract the foes on the table, and we take the maxilla and the mandible backward. But a lot of times with mild to moderate cases could be addressed with terms of headgears way early on. And then you have the vertical maxillary excess. Now, so bimaxillary protrusion is not something that is very, very, unless it's extremely severe, it's not evident in your mixed dentition stage. But your vertical maxillary excess is very, very evident in even in primary dentition. So you will see a lot of, I have a case which I will show you. You will see a lot of these patients with a very gummy smile. And of course, the lip length is not to its full in growth. I agree with all that, but also your maxilla descends downwards with growth, right? So it will be proportionate, because a lot of people ask me this, that, the lip length is not established. How do you, but we do have some cephalometric norms to say that it is a vertical maxillary excess. So if you see a patient with an extremely gummy smile, like even in mixed dentition phase, and you can subject them to cephalometric analysis and then figure out that there is a vertical maxillary excess, then there are some headgears that you can give in the mixed dentition phase to prevent this vertical maxillary excess from getting worsened. Or it sometimes can also, because maxilla is still cancellous and it is pliable at that age, it can have a slight intrusive effect as well. So that's what we think of when we think of class 1 skeletal. Please stop me in case I'm running fast. Please let me know if I'm running fast, so at least I can pace it accordingly. With class 1 dental, you do serial extractions. Of course, there's one point I want to make it clear here, at least for the undergraduates and the beginners in post-graduation. So I'm sure you know that serial extraction is ideally done only in class 1 cases, because a lot of people come later on and then ask me in a class 2 or a class 3 if they could they could have done serial extraction. Ideally speaking, serial extraction is done only in a class 1 dental case where there is severe crowding, and then you want to work around it without complicating it further. Unfortunately, it is not practiced these days because there are a lot of drawbacks with serial extraction, which you can find in any of your textbooks. But it is practiced in very, very selected cases. Personally, I'm not a great fan of it, so I don't really, unless it is very specific, I don't follow serial extraction. However, it can be still practiced if we do a right case selection and do it in the right sequence. Then just for the postgraduate's sake, Graeber Van Isdale has a very, very nice chapter on this serial extraction, which you can go through. Then you have impacted teeth, supernumerary habits, which we saw in the previous slide, which can be corrected for a class 1. I'm not going into the dental. I want to focus more on the skeletal malocclusion. Going into class 2 can be again skeletal class 2, or it could be dental class 2. If it is skeletal, obviously it will have the dental factor accompanying it, but it could be just purely dental as well without the skeletal being included. So that's what we have to remember when we see a patient. So when you see a patient in the mixed dentition stage, and then it's a class 2, angles class 2, you quickly look if it could be a skeletal class 2, which we'll see how we will look for it. And then you confirm whether it is skeletal or purely dental, because your treatment's going to depend on that. If it is purely dental, then you don't do anything then. You could just address to it in corrective orthodontics, because you basically have to move the teeth and correct the malocclusion, which I'll tell you why we prefer correcting it in permanent dentition. But if it is skeletal, this is the ideal time where we can do something. So it could be in a class 2, we all know it could be either a prognatic maxilla, it could be a short or a retrognatic mandible, or it can be a combination of both. So why are we addressing to this now is because we have the growth spurt and we have the patient in the growing phase. So we can do work around these bones to try and normalize them or idealize them as much as possible. So that way, even the dental correction happens automatically. Now, we are able to do this only because that we have this whole growth factor in place. So in a class 2 malocclusion, the straight line that I have on my slide indicates your true vertical. Okay, if for those of you who've done your SEPs, you know what a true vertical is. True vertical is nothing but a perpendicular line to your any horizontal reference plane, like it could be a Frankfurt plane, it could be whichever horizontal plane you want to use as reference, or it could be a line going through the Nasion perpendicular to this. So what happens with this true vertical is it's a reference for you to say, okay, this is where the maxilla has to be, or the ideal maxilla or mandible has to be. Now let's see how much it is off this vertical plane. So it's just means of it could be a soft tissue reference, it could be a hard tissue reference, whichever you want to, whichever you're comfortable using, you could use. I like to use the soft tissue because I could see it clinically and on the CEF as well. So I like to use the soft tissue vertical plane. So you could do this even clinically in a patient. When a patient walks in and they sit on the chair, make sure their head is straight, and then you could use a scale, drop it right from the Nasion point, right? Of course, then it shouldn't interfere the nose, so you'll have to do it slightly off, like over here. And then you could see how much the maxilla and the mandible is in reference to this scale. The other easier way is the 2-finger method when you put this. So if you use these 2 fingers, we have this finger is longer than this, right? So technically, mandible is also slightly backward compared to the maxilla. In reality, I'm saying in ideal reality. So these 2 fingers form as a good reference. So when we keep it, and then we know if this finger is bending or the finger is not even contacting, or this finger is bending and not. These are very arbitrary ways, but then very easy ways to pick up clues as to see if your maxilla mandible is proportionate or not. So all we are looking for is the maxilla and the mandible should be proportionate to each other. If maxilla, so usually we say maxilla is about 2 to 4 millimeters ahead of the mandible in norms, like even in CEF, right? So we are just trying to see if this proportion is maintained or not. It's okay if, the maxilla is off and the mandible is off, then it's both the jaws are, in combination, there is an issue. But to the true vertical, we see how far is the maxilla, to the true vertical, how far is the mandible. And then we get so first you see this clinically. In the soft tissue, you see there is a problem with the profile. Then once you've identified this, then you use your cephalometrics to confirm this numerically and angular measurements. So that way you know for sure you have a problematic jaw, either the maxilla or the mandible. So with regards to in class 2, you could have a prognatic maxilla, that is maxilla is way forward than the true vertical, or also the mandible. And then you could have a retrognatic mandible, means the mandible is way short compared to the maxilla and the true vertical. Or you could have a combination of two. There are only 3 possibilities. You cannot have any other possibilities in a class 2 skeletal malocclusion. So either maxilla is forward, or mandible is backward, or you have a combination of both. So when we look into a class 3 skeletal, it's the bang opposite. So either you have a mandible that is way forward, or you have a maxilla that is shorter. So in my illustration here, in the first, I would have said mandible is way forward, maxilla is normal. In the second illustration, mandible is normal, maxilla is way backward. Or you could have a combination of both, meaning maxilla is also short, mandible is also long, which is the severe form, right? Like where you have a huge reverse overjet. So a prognatic maxilla and a retrognatic, so I think my whatever I've written on the side is wrong. It should be prognatic. 1 second. I think this is hiding. I'm not able to see. 1 second, just 1 second. Okay, I think I thought I wrote it wrong. So it could be a prognatic mandible, or it could be a retrognatic maxilla, or a combination of both. So far we are clear. So when we see a patient in mixed dentition, it could be a class 1 skeletal where you could see a vertical maxillary excess. You don't really see a bimax at this age. It could be a class 2 skeletal where you would see a mandible that is either short or a maxilla that is either long, just to be in colloquial terms, long maxilla and short mandible. Or it could be a class 3 skeletal where you have a long mandible and a short maxilla, or again, a combination of both. So these are the only skeletal scenarios that you will see in a mixed dentition patient. So I hope it is not scaring you. We can try and fix it, but then again, there is the right age and the right parameters that we need to address to fix it. So when do we do this? How do we predict this growth? What are the considerations that we need to consider? So going into transverse, anteroposterior, and vertical growth completion in patients. This is a beautiful actually the tabulation is what I formulated, but the content is from this book. Anyone who wants to read clinical orthodontics, which will help you in children, you must, it is not just a pediatric orthodontic book, but they have a lot of information for pediatric orthodontics. It's a nice, it's a British author, very nice book. It is available as ebook, if I'm not wrong. If I have one, I will send it to Dr. Sharad. Please take it from Sharad sir. It is not for just postgraduates or undergraduates. It's also for clinicians who are practicing. It's a very clinically oriented book. So if you look at this tabulation, you will see when the transverse, anteroposterior, and vertical growth completes. So the first to complete is the transverse. So any form of expansion or a maxillary expansion that you want to achieve has to be done early, just because the transverse growth gets completed very, very early on, right? And then comes the anteroposterior, and then comes the vertical growth. So we're really not concerned about the vertical. We have to finish your transverse and your sagittal correction. So transverse is anything in this dimension, sagittal is anything in this dimension, and vertical is up and down. So that is why we always say we'll have to do your expansion treatment early on, even before you do any form of overjet correction or, aligning or any form of sagittal correction. Your transverse has to be done early. So when do we act and why? So there are two things that we have to keep in mind. We are dealing with two different jaws. We are talking about the maxilla and we're talking about the mandible. Now, maxilla has its own growth gradient. Mandible has its own growth gradient. So studies have shown this. You will find a lot of articles, a lot of textbooks. So I'm sure most of you are aware of it. Mandible has its peak velocity, peak growth velocity during the pubertal growth spurt. So that is where you want to act when you want to target the mandible. Now, it is not very generalized. So you can't say, okay, I will correct a class 2 at this age and a class 3 at this age. No, you will correct a class 2 with a mandibular problem at a particular age, and a class 2 with a maxillary problem at a particular age, because we are dealing with two separate wounds. That is why the earlier slides were very important. You can't just say this patient has a class 2 skeletal. You should be very specific, saying this patient has a class 2 skeletal with a retrognatic mandible, or this patient has a class 2 skeletal with a prognatic maxilla. Because if you're talking about maxilla, the sutures start interdigitating at 10 years. If you see Melson studies, it shows it starts to interdigitate by 10 years of age. So anything we do after 10 years of age is not going to be very fruitful in terms of maxilla, because once the sutures start to interdigitate, once they start to tighten up, it's very, very difficult to cause any form of movement in the maxilla. So if you have to address to the maxilla, it has to be way within 10 years of age. So that is why it is very important to know which bone we are targeting. Now, if we're talking about the mandible has its peak velocity, as I said, at the pubertal spurt. So now the pubertal spurt again varies between boys and girls. So if you're talking about in general, boys and girls in general, you will address the mandible at the late mixed dentition, because you want to target the pubertal spurt, whereas the maxilla has to be addressed in early mixed dentition. Now, why do you see most of these class 2s treated in late mixed dentition? Somebody might ask me in the group, but why do we generalize class 2 as late mixed dentition? Because I hope I'm right with the percentage. Over 85%, 80 to 85% of the class 2 skeletals are all retrognatic mandibles. Rather, to say it in simpler words, the most common class 2 skeletal is a retrognatic mandible than a prognatic maxilla. Most of the time, you will see combination prognatic maxilla and retrognatic mandible, but just per se, prognatic maxilla with a normal mandible does occur, but the percentage is very, very less. So in general, when you're seeing a class 2 skeletal, most of the time is a short mandible, or it's a combination. So it's usually addressed at late mixed dentition. Whereas I'll tell you why in detail later, but then this is a very general norm. In a class 3, whereas in a class 3, which we will see, it's the opposite. Most of the time, The problem is, again, the maxilla, not the mandible. Again, we will discuss that. So far, I hope you understand, we are dealing with class 2 skeletal. In a class 2 skeletal, we cannot generalize. We have to first identify if the maxilla is problematic or mandible is problematic. If it is a mandibular problem, then we address it in late mixed dentition because we want to use the pubertal growth spurt. Now, if it is a maxillary problem, we address it in early mixed dentition because we want to use the open sutures, make use of the open sutures to do any form of expansion or, mild. You can't really distalize the maxilla, but at least hold it in place to prevent it from further moving forward. So this was just to summarize. So if it is a prognatic maxilla, you know what you have to do. If it's a retrognatic mandible, you know when you should address. If it is a combination of both, then we address both the jaws. So how do we diagnose this? First, facial evaluation, like I mentioned to you earlier. Patient walks in, make them sit. So the best way to do is sit and have a full-fledged conversation with the patient. Anyway, that will also help in your rapport and relationship with the patient. It will also help you to see the patient in different angles. We call it the dynamic smile. We'll have to evaluate them in a dynamic smile, not just tell them smile and capture a photograph. That's not going to really help. You need to see when they're talking to you, when they're smiling, the natural smile, how far the lip extends, how much gummy is the smile, or does the teeth even show when they're smiling? So I know with pediatric population, this is less of concern. It's more on the geriatric population that we worry about all of this. But however, so having said that, there are a lot of cases where you, like I mentioned, you have gummy smiles. You might have a very short upper lip, unusually short, which you can pick up at that conversation. So that would help you also to evaluate, is the jaw a little off? You might not be able to say which jaw is problematic. Is it a class 2? Is it a class 3? No, but at least when you pick up that there is a problem with the jaw, there is something wrong, there is something off, then you start to dig in further to find out, okay, where exactly the problem is, right? So then you could use a 2-finger method, you could use a scale, you could say, okay, roughly I know there is some kind of an issue, or, you could just say convex profile, concave profile, all those points that you see in the facial evaluation textbooks, right? They are very, very key indicators to say there is an issue. And then you start doing a cephalometric analysis to see if, there is really a skeletal problem. And then you can see the occlusion as well. The occlusion actually gives you a lot of clues. Now, say if you see the occlusion and then you say, okay, the patient already has a dental class 2. So does he have an underlying skeletal problem? Or is the dental class 2 purely dental because of habit or because of missing teeth, because of extra teeth, So if it has to be a class 2 dentally, there should be some local factor. If it is not a skeletal problem, there should be some local factor causing it. So you start to identify, because unless we dig and see what the etiology is, we are just blindly correcting the occlusion, which is no good. Because what if there is an underlying habit? What if the tongue is a problem, which I will deal with at the end, because this is a very new concept that is picking up in the West in a big way. I mean, it's not a new concept, but it is looked at it, maybe look at it in a new, or it has a new perception now compared to what it had earlier. So the tongue also has a very, very important role. So we have to see if any of these are contributing factors to the underlying skeletal problem. So say if it is not skeletal at all, it's just purely dental, then we have to find out why is there a problem, even if it is purely dental. So like I said, occlusion gives you clues. Now say a patient has an open bite. The patient has an open bite, then you should quickly think, why is he having an open bite? Is there a habit? Or is the bone itself, canted up and down? So is there a skeletal problem underlying it? Or say patient has a deep bite, then okay, probably the mandible is inflated upwards. So you can relate, like open bite, they're going to have a high angle. close bite or a deep bite, they're going to have a very low angle, in your cephalometric analysis. So these are factors that could correlate. So you can pick up these even during your clinical evaluation and then counter check it with your cephalometrics. So then you're going in the right track. So patient comes, you've identified something that is wrong, and then you do your ceph analysis, and then you take it further on. Now, when mandible is at fault, now we are only discussing class 2 right now, right? So class 2, we saw it could be a mandibular problem, it could be a maxillary problem. So if it is mandibular problem, it's usually a short mandible. So then what do? The treatment option would be a functional appliance or a myofunctional therapy. It needn't be just a functional, it could be even trainers or your aligners nowadays, but some form to bring the mandible forward, right? And then when is it done? It's just prior to pubertal growth spurt or late mixed dentation. Now, why do I say just prior? Is because the patient will take some time to get used to the appliance. You need to motivate the patient. It'll take at least 1 to 6 months, depending on the patient's compliance and as to how they're going to adapt to these appliances. So if you are going to just drop it in the patient's mouth at the pubertal spurt and say the patient doesn't wear it regularly and you miss that 6 months of the pubertal spurt, then it's not going to be very ideal, because you need that you need maximum wear at the pubertal spurt. So we always say drop it in a couple of months earlier than the pubertal spurt. Give the patient enough time to get used to this whole new feeling of having an appliance in the mouth. So by the time they get used to it and start wearing, so don't do it way early as well, then you'll have burnout. But then just a couple of months, say 3-4 months earlier, so give them enough adaptation time. And then at pubertal spurt, they're wearing it at the maximum hours, so you get the maximum benefit out of it. So you have studies that support functional appliance therapy in class 2. There are a lot of studies that contradict it as well. But having said that, these studies have its own drawbacks. There have been RCTs done, systematic reviews done. So they have their own drawbacks, because no 2 patients are the same, no 2 class 2s are the same, and no 2 patients respond the same way to treatment. So there's a lot of supporting and contradicting literature, but of course, even the contradicting literature cannot just prove something statistically, but they can never say it works the other way around, like harming the patient. So definitely you do see a lot of improvement in patients' profile, patients' occlusion, and then patients sometimes even in their speech and airway. Now airway is a big it's a big game these days. So when you bring the mandible forward, automatically you're opening up the airway, and that eases a lot of things for the patient henceforth if they have a pre-existing constricted airway. So that is something we have to keep in mind as well. So it greatly enhances positive behavior and has a great influence in psychological well-being of the patient. They have shown to decrease incidence of trauma in class 2 to 1 cases, because the proclination comes down, right? Once you do a functional appliance and correct, the proclination automatically corrects, and then it brings down the incidence of trauma to the anteriors. They have greatly improved quality of life in patients. Like I said, airway obstruction, helping them. When you bring the mandible forward, obviously you're releasing the airway as well. So this is one patient whom we saw early on, and then we followed up, and then he came back at the right time. He was a typical class 2 with a retrognatic mandible. But in this case, it's more of his lip. That's one thing I want to mention here, that a lot of times you will see this mandible is stuck inside because of a muzzle factor or a functional retrusion, we call it. So it could be a lip trap, it could be any other strong musculature that is preventing the mandible from moving forward. So it could also be an occlusal factor. So the functional retrusion could be even because of an occlusal interference or an occlusal factor that's holding on, like say in a div 2 case, right? In a class 2 div 2, a lot of times when the incisors like way retruded in a severe div 2, the mandible is restricted from moving forward and growing ahead. So if these functional retrusive factors are relieved at the right time, you don't even have to do anything to the mandible. It will just beautifully come forward by its own. So this one case has this functional retrusion because of the lip wrap. Yes, he has a short mandible, obviously, because it's not grown. He has a very strong lower lip that's holding it back. So that was his occlusion, and then his CEF and OPG. And then we decided to do a bionator for him, not a twin block. I'll tell you why. Because when you when you see the history of functional appliances, which we will discuss in a little more detail in the afternoon section, you will see that there are appliances that are tooth bone and tissue bone or a combination. Like if you see activator and twin block, they're completely tooth bone. They have very less effect on the muscle directly. Indirectly, yes, all the appliances will have muscle activity, but direct activity on musculature is pretty rare. But if you see a bionator and a frankel is a completely tissue bone appliance. It has a lot of effect on buccinator and your lips, and but again, it is not a very comfortable appliance from a patient's perspective, right? So then bionator comes as a beautiful combination between these two, because in a bionator you could add this lip wrap, a lip bumper to hold the lip away, which could beautifully work on the muzzle, and also a tissue tooth bone appliance. So it is quite comfortable for the patient to wear. It's not as bad as your frankel, but it also keeps your muzzle away. So it's a very, very nice in between neutral kind of appliance to drop into the patient's mouth. So that was just I'm not showing you every picture because there's a lot of slides to cover, but my essence over here is to just show you the difference in his mandibular growth just by giving a lip bumper on the bionator. Honestly, I don't believe the bionator did any effect in bringing the mandible forward. Once the lip was relieved, I think the mandible by itself popped up. So that is the power of keeping a strong interference away, whether it is tooth interference or a muzzle interference, to help in your mandible coming forward. So that, and then we shifted him onto a twin block, because a bionator has a beautiful muzzle effect, but the sagittal correction, how much you can bring it forward in terms of teeth, you can't, you don't have the luxury like you have with the twin block. So we shifted him from a bionator to a twin block just to achieve more sagittal correction dentally. And so that is one more point I wanted to mention here, that you could use a combination of two appliances to get the maximum effect out of it. So effects of a functional appliance, what a functional appliance does. I don't want to go into detail of this because we are covering this in the next session, but I had just added it here for completion's sake. So how do you check? Again, pterygoid response, which we will see in the afternoon slide. So, but I'll just give you a summary of it. So you will see the pterygoid response in 2 weeks. So once the patient is wearing the appliance for 2 weeks and you call them back, if they have been very regular with the appliance, when you take off the appliance and ask the patient to bite, and then they will automatically bite in the forward position. You try to push it backwards, they will elicit pain in the condyle region. That is because of the pterygoid muscle that has, so the pterygoid muscle constricts, right? So when it constricts and then it stays in there for a while. So because you're bringing the jaw forward. So when you try to push it back, then there is pain in your pterygoid, lateral pterygoid. So that's what we call the pterygoid response, which you will elicit in 2 weeks, minimum 2 weeks of wear. So again, we're going to do this in detail in the myofunctional therapy. So what happens if the maxilla is at fault? So now we were doing class 2 skeletal, just to recap, we were doing class 2 skeletal, and we were seeing when the mandible is at fault, right? Like there is a retrognatic mandible. What do? You do when do you address and what you do, correct? So now what if the maxilla is at fault? Then you will have to do headgears or orthopedic appliance. So when do you do this? You do this early on, that is in early mixed dentation. Because again, like I explained, the sutures, interdigitation of the sutures. So you need to address it and early on. And what do you do? So you can give them headgears. There are 3 types of headgears: high pull headgear, low pull headgear, and a combi pull headgear. So now when do you use what? Just looking for my water, sorry. So high pull, low pull, and combi pull headgear. So now this purely depends on the growth pattern of the patient. Let me explain that to you. I have some illustrations here. Yeah. So when the patient is a high angle case, okay, so first let's see what the headgear does. So then you'll understand where to use the headgear. Like this is an example of a high pull headgear. It goes way up here. Okay, actually she is wearing it slightly low. It goes a little further up. So in a high pull headgear, the force is right from this region, right? Like way up. So when you have a force vector, so basically where do we attach the headgear? I'm just saying this for the interns and the undergraduates, whoever's in the group, because sometimes when we read, right, like we don't know where it is even attached to say where the force will act. So a headgear has a face bow. If you see this girl, she's wearing a metal face bow to which the strap is attached. So the face bow is actually attached to the maxillary first molars. So the only point of contact on the dentition for the headgear is the maxillary first molar, where the face bow is attached, and it has an outer bow which is attached to the strap, right? So the force vector technically acts over the maxillary first molar. Now, why do we act here? Because the center of resistance of now I'm not going into this whole center of resistance. It's a huge topic. If you want, we can cover this. It's the biomechanical principles of tooth movement. We can cover this in the discussion in a gist if someone wants to learn about it. But to summarize, we ideally have to act as close as possible to the center of resistance to get bodily tooth movement. Whether it is skeletal, whether it is dental, we have to go as close as possible to the center of resistance. Because if the more we go away from the center of resistance, you're going to create a rotation, right? Like this, if I want to move this mobile from here to here in a bodily movement, I have to act center of resistance. Now, if I do this, if I act here, I'm going to create a tilt. If I act here, I'm going to create a tilt, right? Because I'm going away from the center of resistance and I'm creating a rotation. Like say you want to move your friend from point A to point B, you're fighting with them and you want to push them. If you push them by the hip, they'll probably move bodily, right? But if you tap them on the head, they're going to fall like this, okay? Or if you tap them at the foot, they're going to fall this way, right? So you're creating a rotation when every time you move or apply force away from center of resistance. So technically in orthodontics, you want to create bodily tooth movement, right? Like whether it is teeth or whether it is bone. So you want to act as close as possible of center of resistance. Now in teeth, that's not possible because the center of resistance is way up. It's 1/3 at the apical part of the root. So that's why we have other parameters, which I'm not getting into now. But here you want to act as close as possible to the center of resistance of the maxilla, which was between the 5 and the 6. The center of resistance of maxilla is between the 5 and the 6 roots at the tip, closer to the tip. So if you go to the 5, you're going to go a little away. So you try and stick to the 6 where you're as close as possible to the center of resistance. So that's why we attach it to the first molar in the maxilla, the face bone, right? So you put 2 buccal tubes, you attach it to the first molar. So now when you apply force, how are you applying force? From the strap? The strap has an elastic module, it goes and it attaches to the face bone. So there is a pull. So the force is acting in this direction, like the line that I've shown in the illustration. It's acting in the upward direction because the high pull headgear, you're acting from way up. So the line of force is actually going up. So it has an intrusive component, right? Like the arrow, the 2 arrows I've shown, it has a upward intrusive component, and it has a distalizing component because it's from back. So there's the point of application, the point of application of the force is here, of course, but then the molar is here, and you're pulling this like this. So obviously it has a backward and an upward pull. So it has a distalizing component and an intrusive component on the tooth. Of course, on the skeletal base, but also more so on the tooth, right? So now what happens if this patient, okay, say this patient has a deep bite. Just example, I'm saying this patient has a deep bite. Now, if you're going to include the molar and the maxilla, just because you want to hold the maxilla backward, if you're going to end up giving him a high pull headgear, you're going to intrude the molar and create more deep bite. The patient already has a deep bite, and you're going to create more deep bite because when you anytime you intrude the molar, it's going to deepen the bite, correct? So it is not a good choice. So where can you use it? If the patient has an open bite, say patient has a nice open bite, the intrusive component is going to benefit even closing the bite. Right? I hope I'm not fast here. I just want you all to get this. So if the molar is going to intrude, obviously you're going to close the bite as well. So it helps in bite closing, and it also helps in holding the maxilla backward. It doesn't really cause distalization of the maxilla, but it will hold the maxilla backward. So high pull headgear is preferable in patients who have open bites because the bite will also close and it also holds the maxilla backward. You cannot use it in the opposite, like a deep bite case. Now, if you think of a low pull headgear, it's exactly the opposite. You pull it, sorry? Okay, so if you're pulling it from the neck, the strap is on the neck. I think I have a picture. Maybe it will come in my next presentation. So if you're pulling it from the strap, the cervical pull headgear comes on the neck, the strap. So you're pulling it from down. The force vector is like this. So you're pulling it downward and backward. So again, this is not attached to the lower molar. I know it might sound silly, but a lot of people have this doubt whether this will be attached to the lower molar. No, headgears are always attached only to the upper first molar. So you're again pulling the upper first molar down and back. Now, I know we are aiming at skeletal, but then imagine with the teeth, so you'll understand this. So when you're pulling back and down, you're going to create, or rather create an extrusion, right? Extrusive component of force. So in a patient with a deep bite, if you extrude the molar, obviously it will help in bite opening. So this is very, very ideal in cases where you have deep bites. So it will keep the maxilla backward. It will also have an extrusive force component, which will help in opening the bite. The combi pull is in an average mandibular plane angle, like the bite is normal, the mandibular plane is normal. You don't want any vertical component. You just want only to hold the maxilla backward. Then you give a combi pull, meaning you have a force vector from here, and you hold the maxilla quite, intact, so that you only have a backward or a distalizing component, which will hold the maxilla from preventing it come forward, but it will not have a vertical component of force. So those are the 3 types of headgears. Because I'm not covering headgears in detail in the next session. The next session is purely myofunctional. So if you have any doubts with headgears, please feel free to ask me in this session itself. So, 1 second, sorry. Yeah, so this is just a recap. If it is high pull that you're using, it's an open bite or a high angle case. If you're low pull you're using or a cervical pull, then it is in a deep bite or a low angle case. Then if it is a combi pull, then you use it in an average angle case. So this patient is actually a deep bite patient for whom we used a cervical. So that's a picture that I wanted to show you with the cervical. So he also has a twin block, which we will be discussing in the next session. But to address, he's a combination. He had a maxillary and a mandibular problem. So to address his maxillary component, we gave him a cervical pull headgear because he had a deep bite. He was not an ideal case for a high pull or a combi pull. So he had a cervical pull headgear, which had the force component acting from the neck. So in a class 2 skeletal, this is again a recap slide. If it is a maxillary problem, we address the maxilla early on. We decide what headgear we want to give depending on his bite. I mean, not just bite. What I mean is the mandibular plane, high angle, low angle, average angle, and you address it early on in early mixed dentition. If it is a mandibular problem, you take care of it with a functional appliance and you address it in the late mixed dentition. Now, what functional appliance to choose, how to choose is a whole session that's coming, so I'm not going into that. Now, let's go on to class 3. Now, in a class 3, like I said, in a class 2, if it's a combination, like the last case I said, you could do both. You could do headgear along with a twin block, which we will, I'll elaborate in the next lecture. So if it is a class 2, you have a mandibular component, you have a maxillary component or a combination. Now, what is the mandibular component? It's a prognatic mandible. What is the maxillary component? It's a retrognatic maxilla or a short maxilla, or it could be a short maxilla and a long mandible. So what do you treat? How do you treat? And why do you treat? Now, same diagnostic evaluation like we did in class 2. The patient walks in, you sit, you have a conversation with them, you talk, you chat, you laugh, you play, and then you figure out that, okay, there is something off. So if it is a long mandible, it will be so obvious. Like now it's a fashion statement, right? Like after, I think, post Angelina Jolie, I think it's become a fashion statement to have a prominent chin button. But yes, it depends. Like in some people, to a mild amount of prominent chin button is considered aesthetic. But again, it depends on patient and their preferences. So you have a conversation. You will pick up a prognatic mandible way early on. Like it's so prominent and it's so obvious. But if it is compared to a class 2, I think picking a class 3 is much easier. So what you are again looking for is there a discrepancy both in the maxilla mandible? You will not be able to come to a confirmation at this point, but to some extent you will have an idea. So we also look for things like mentolabial sulcus. We look for this fold that we have here. Yeah, so the malar prominence, that's also something that you can look for. So in a patient with a very prominent maxilla, like in a class 2, right? This fold will be obliterated. When they smile, you will actually not see this fold at all. It will be obliterated. You can also look for the nasolabial angle. In a patient with a very extremely prognatic maxilla, this angle will be so acute because of the proclamation. And in a patient with a very deficient chin, you will actually see a very shallow mentolabial sulcus. But in a patient with like a class 3 with a very prominent chin and a prognatic maxilla, you will see like again, it depends. The teeth are proclined, you'll end up seeing a deep mentolabial sulcus. Even in a class 2, if you have, so mentolabial sulcus will also give you an arbitrary reference as to whether the lower incisors are proclined or not, right? So these are also factors that you can consider. Now, if they have a mid-face deficiency, it will be very obvious because this whole part will be ditched in, right? Like you will actually see this entire mid-face inside. So that is also a very obvious feature that you cannot miss. So in a class 3, a lot of times we think the mandible is at fault, but they say in a lot of cases, it's the maxilla that is deficient. So that is why the treatment options actually that is also one of the reasons why the treatment options shifted. Now, in those days, they used to address to the mandible, right? They used to put this chin cup therapy, but chin cup therapy is not widely used these days because of the reason that it actually worsens the class 3. We will see how. So what do you do now? You see the patients same like what you did in class 2. You evaluate, you get a rough idea that something is wrong, go into your cephalometrics, take the ceph and do your analysis, and you will know pinpoint maxillary problem or mandibular problem. And then of course you evaluate the occlusion, which will give you clues as well. So what do you do? Now in primary dentition, if it is a skeletal class 3, that is mesial step greater than 3 or like 3 mm or greater, it is indicative of a skeletal class 3 in primary dentition. But you don't really do anything. Like I said, you will warn the patient, you will prepare the patient, you'll counsel them, and then you'll tell them what all they can anticipate. If it is dental class 3 in primary dentition, meaning if it's dental class 3, it will be a less than 3 millimeters, which indicates more towards a dental class 3, which can be addressed with dental correction later on. And in both, you will have anterior crossbite. So anterior crossbite itself doesn't mean it should be a skeletal class 3. The indicator would be how much of a mesial step you have in primary dentition. This is one of the indicators to differentiate skeletal and dental in primary dentition. So this patient came to us, I think she was 14 years when she came. And then she had this class 3 occlusion. So most developing class 3 malocclusions display anteroposterior and vertical maxillary deficiency with normal to slightly protruded mandible. So this is what I was trying to tell you early in the earlier slide, that most of the class 3 occlusions, the problem is actually the maxilla more than the mandible. They might have a mild mandibular component, but like if you see her, you would immediately say, like, yeah, if you've not done yourself, you'll say, oh, she's got a prognathic mandible, right? But actually her mandible was almost normal. I think there was a very, very slight protrusive component on the mandible. It was not very significant to the maxilla, but her maxilla was way deficient, both vertically and sagittally. So that is one factor that we have to remember, that it is most of the time that maxilla is actually the problem in class 3. So when we did the cephalometric analysis, we found that it was majority, it was the maxillary component compared to the mandibular component. So you will also have to differentiate between pseudo and skeletal. So children with anterior crossbite had a smaller anteroposterior cranial base, maxillary retrusion with a normally developed mandible, anteroposterior. This is how you say it could be a pseudo class 3, right? And also here we'll have to discuss functional shift, right? A lot of times the patient say, okay, let me give you this example. Say you have a patient with bilateral posterior crossbite. They have crossbites on both sides. Now, there is no way a patient can occlude and chew his teeth, right? So what nature does, or the TMJ and the muscles automatically do, they shift the mandible to a point where they get occlusion on one side and they get an exaggerated crossbite on the other side. So this is just nature's compensation to try and achieve an occlusion where they can choose some kind of food. So if it is a crossbite, bilateral crossbite, and then the patient comes to you, and when you see the patient, they will actually have a unilateral crossbite, an exaggerated unilateral crossbite, but you'll see the jaw is deviated on one side. So when you look for that and then you relieve that deviation, you'll actually see the true occlusion is actually a bilateral posterior crossbite. So now how do you identify this? So you will actually see the jaw is shifted. You will see some kind of asymmetry when you see the patient itself, clinically. The other way to do this is when you ask the patient to bite, right? You will see the midlines are in one position. Say the lower midline is to the right of the upper. Okay, example. So when you ask the patient to open their mouth completely, like full mouth opening, you'll see the midlines are coinciding, or it will be in a different position compared to what you saw in occlusion. So that means when the teeth are not contacting, that is, the teeth are out of occlusion, the patient's jaw position is different. And when the patient tries to bite, when the teeth initially contact, automatically it shifts and it goes to a new position. So this is what we call functional shift. If there's anyone who's not understood this at this point, so if you don't mind, can they ask me? Because this is very, very important for them to understand. I don't mind repeating it, but if there's anyone who doesn't understand this and who wants me to repeat this. Okay, so I just assume you've understood. So this is very important because this is where we identify a pseudo class 3, because when they tend to shift the jaw, obviously the jaw comes forward and it looks like a anterior crossbite with a class 3 occlusion. So what do you do for this? We'll have to first identify this. Once you've identified this, you have to put the patient on a deprogramming splint, meaning you completely disocclude the upper and the lower teeth for 2 weeks. So when you disocclude them, then you know where the interference is. Then that needs to be addressed, meaning you'll have to correct the interference with braces, with aligners, or with coronoplasty, whatever. If it is mild, you do coronoplasty, but then otherwise you do some form of alignment to correct that, relieve the functional shift, and then you will have to evaluate. So what we usually do once we deprogram, we do like we articulate it in a fully adjustable articulator to see where all the or a semi-adjustable articulator to see where all the interference is, and accordingly that is the ideal occlusion that you will get of the patient, and then further on plan treatment for that patient.
For how long should be the deprogramming done?
You cannot do that beyond 2 weeks. The maximum you can do is 2 weeks because the joint will not take up more than that. Okay, so the next is if the maxilla is at fault. So now we were discussing about the class 3, right? So in class 3 you have maxilla at fault and mandible at fault. Now we are talking about maxilla at fault. So now what if the maxilla is at fault? So it's a short maxilla, vertical deficiency could be there. So then we do a face mask therapy or a reversible headgear. Now this face mask therapy has to be addressed in early mixed dentition. Why? Because same concept. Maxilla, you want the sutures to be loose. You don't want them to be tight. So you have to address it in early mixed dentition. So you put in the reversible headgear in early mixed dentition, try to bring the maxilla forward. In doing so, it's usually good to do a little bit of jiggling of the sutures, we call it. So what we do is we put an expansion screw along with the splint of the face bow therapy. So what we do is we activate, deactivate the screw. So what basically you're doing is you're opening the suture, closing the suture, opening, closing, like you're basically jiggling up the sutures or loosening it so that the maxilla comes forward faster. So this has been documented in various articles. It's a very commonly used protocol. So you protract the maxilla. That's one. And the face bow itself has a small chin cup component which just holds the mandible. It doesn't apply any force on it, active force on it, but it just holds the mandible there as you're protracting. So it's like a would you say, it also helps in terms of anchorage, right? So, and it as it's working as an anchorage, it also benefits from holding the mandible. So that is with terms of a reversible headgear.
Could
So
you explain the jiggling concept that you just now mentioned?
Sorry?
Could you re-explain the jiggling concept?
Oh, yes. Yeah. So if you see, this is a splint that only covers the molar and the two premolars, but usually we prefer also giving a full maxillary splint, and then we have a screw that is placed in the center. So why do you do this? You're not causing an active expansion as such. What you want here is we activate and deactivate, like we do one turn, you know. So when you do that for, I think the protocol is 14 days, when you do this jiggling, what happens is you're loosening the sutures that are present, because when you activate, obviously, you know, you're trying to open the suture and then you close it and then you activate again. So you are actually loosening up the sutures. So the movement of the maxilla to come forward, the protrusive movement is faster. So that is what is done with jiggling of the sutures. I have the article, I can share it with, actually it's there in a lot of articles, but I have the main article for that. I can share it with Sharad sir and he can pass it on to you all. Let me look through it. I should have it in my hard disk. But you can actually, this is not a very new concept or anything. It's been practiced for many years. You'll actually find it even online. But I'm just trying to explain it here. So for those who are not aware, can go back and read. So that is done. And then along with the face traction, you see the rubber bands that are placed. So that actually pulls the maxilla forward. So going back to this chart, so why I said we have to start early on, because again, when you want to do any jiggling and loosening the suture and bringing it forward, it has to be addressed early on, because one transverse gets completed first, and also the fact that maxilla, the interdigitation also starts by 10 years of age. So it's always better to address to the maxilla in early mixed dentition. So you have articles that also show that, you know, with a little bit of expansion, you can one second, sorry. So why do we have to know about palatal expansion is that because in both class 2 and class 3, actually in class 3, you don't really use it, but in class 2, in most of the cases, right, what happens is, if you look at the way a class 2 dental or a class 2 skeletal is formed, like for example, say a patient is a thumb sucker, right? In a thumb sucking patient, the most common problem is a class 2 skeletal base. Now, why this happens is when a patient is sucking his thumb, right, the mandible is dropped. The mandible is dropped most of the time. Say a severe thumb sucker, right? So when the mandible is dropped, what happens is the maxilla and the mandibular teeth don't really occlude. So there is so usually we have this buccinator mechanism, right? You have the buccinator muscle from outside acting on the teeth from the outside. You have the tongue from inside neutralizing the effect of the buccinator. So the teeth are actually maintained in a neutral zone. But in cases where, you know, say mouth breathing or they have this thumb sucking habit, the mandible is dropped down. Now, the buccinator is acting on the maxillary teeth, but there is no tongue to counteract that, because when the mandible is dropped down, the tongue is also dropping down. So when that happens, the buccinator actually constricts the upper arch where there is no muscle from inside to hold it. So there is a maxillary constriction that is very, very evident. Now, this is in habits. Now, say a retrognatic mandible, a short mandible. Now, in a short mandible, the same problem applies. There is no enough tongue pressure to act on the entire maxilla because the mandible is backwardly placed. And because of that, there is some amount of constriction in the upper arch because the maxillinator muscle is very strong and it's acting on the upper arch. Now, this is the reason why you see in most of the class 2 patients, whether skeletal dental, you'll see a lot of maxillary constriction, palatal constriction. And then you need to do palatal expansion to allow for the normal neutral position of the teeth. So this is just to talk a little bit of palatal expansion. So you could do slow or rapid palatal expansion. It is not, what do you say? Statistically, there is no difference. You could do either one, whichever is comfortable for the clinician. So in a class 2, you will have to definitely expand because if you don't expand, like say if the palatal arch is, say the upper maxillary teeth are constricted and you're trying to bring the mandible out, right, like forward. So what happens is the mandible has to occlude with a very narrower portion of the maxilla because it is constricted. So this is the reason why you have to expand to allow for the broader portion of the mandible to come forward and occlude normally with the upper. Otherwise, you'll end up like in a mild frostbite because the palatal, the maxillary teeth are constricted and you're bringing the broader portion. Now, when you bring the mandible forward, you're actually bringing the broader portion of the mandible forward, right? The broader portion is at the back. The narrow portion is in front. So then you need the upper arch to be broad enough to accommodate for the broader portion of the mandible. So you will have to do an expansion.
A small question. Could you please share your views about the stability of the palatal expansion post-treatment? How do we maintain that?
Stability, sorry?
The stability of the palatal expansion. How because in some of the cases it tends to go back once the palatal expansion is removed.
Okay.
How can you ensure the stability of that? Could you share a few words on that also?
Yeah, sure. So that's again a huge topic, but I'm going to give you a very, very small hint here. When we do a palatal expansion, it's very, very important to know what kind of expansion we are doing. So for this, the easiest way, if I'm sure you'll be aware, is to actually cut the cast posterior to the 7. So what happens, you will know how the teeth is tilted in the alveolar bone. Now, suppose this is the alveolar bone and this is the molar, right? Now, say the molar is placed ideal, like say it is in the straight inclination to the base. And then you're trying to expand. You're actually tilting the tooth more buccal. This has a very, very, very high tendency to relapse. Whereas if the teeth are, say, like this, right? Already, the inclination of the tooth is very lingual in the cast. And then you're trying to expand, you're bringing it to ideal position. That is a very ideal way to expand. So in simple words, if you have your tooth inclination to the alveolar bone in a very ideal inclination, you can only do a skeletal expansion. Any form of dental expansion is going to cause a relapse. But whereas if you're going to have an already inclined tooth on the alveolar base and then you are expanding, the relapse is much, much lesser. Just give me 1 second. I'm just going to come in a minute. Please excuse me. Just give me 1 minute. I'm so sorry. I'm so sorry for that. Was that clear? You want me to repeat that? I can try to draw it for you. Maybe at the end of the session, I'll just make a diagram to explain that. But is that clear for what I was trying to say?
Yes,
With regards to, please excuse my little one. She was crying outside. That's the reason I had to open the door. She'll just hang in here for 2 minutes and she'll leave. Please, I'm so sorry, sir, for this, but she's not going to listen otherwise. So this is the base. And then this. So like I said, if the tooth is already normally inclined to the base, the roots are already normally inclined, and then you're going to expand it, right? So you're going to create a wrong inclination of the tooth. This has a higher tendency to relapse. So when you will see that is in a completely it's a skeletally constricted maxilla. So in that case, if you address way early and you cause skeletal expansion, and see, when you expand skeletally, you'll also tend to expand dentally, right? So you will cause slight inclination, which will have a tendency to relapse. But you will, in such cases, what we do, we over expand. So then when there is a relapse, we accommodate for that little bit of relapse, right? So we have to plan this way, way early. But if it is inclination is already off initially, and then you expand, you don't expect much of relapse to happen. So there you don't really need to over expand. So I hope that itself will give you a big difference between skeletal expansion and dental expansion. If it's only an inclination problem, you can just stick to dental expansion. But if it is a skeletal problem, meaning the inclination is normal and still there is a cross, right? Means you have to do a skeletal expansion. And if you're doing a skeletal expansion, you have to see the patient way early. Or if you're going to do it in, say, teenage, you'll have to do like a SARP, surgically assisted rapid palatal expansion. So unless we do this, it's going to be very, very difficult for us. And like I said, we over expand a little in such cases because we know that the dental expansion that we have caused will relapse because of the inclination, and then we accommodate for that. Is that okay?
Beautifully shared, ma'am. Thank you.
Yeah, no worries. So expansion is a big topic. I have not covered in this, but I thought, okay, at least this much I will tell you. So with regards to the mandible, as I mentioned earlier, the chin cup therapy is not going to be very, very effective. It's not widely used these days because what happens is when you apply force on the chin, active force on the chin, it is impossible to actually push the mandible backward, right? Like it's all in the glenoid fossa, your condyle is there. So what happens, the force actually directs the mandible to grow downward and backward. So we are technically elongating the patient's face and actually worsening the aesthetic profile of the patient. So this is the reason why the chin cup therapy is actually not practiced these days widely. And the other reason, like the article I had mentioned as well, right? Most of the time it is the maxilla that is which is problematic more than the mandible. So in most of the patients, when you address to the maxilla and just hold the chin itself, you get beautiful results compared to actually effectively addressing to the mandible. But again, you will confirm all this with yourself. It's not an arbitrary thing that we are talking about. So you're going to confirm it with the cephalometrics and then take it forward. Okay, so where is my next? 1 second, I'm just trying to move it. Sorry. Why intervene early? Because you want to avoid complications. What complications can you see in a class 3? You can see this kind of gingival recession because of the traumatic bite, they have a cross bite, and because of that, you'll see gingival recession. You can see incisal wear. Because of the incisal wear, you can have condylar issues as well, TMJ problems. Most of these patients end up with click or some kind of TMJ abnormalities because of the bite as such. So you will have to prevent all of this, and because of that, you will have to intervene early. And of course, worsening of your aesthetics, right? Like it kind of the class 3 actually worsens with age, so you want to address it as early as possible. And if we address it early on, we can even prevent a surgical procedure from happening for the patient later on. Or sometimes you cannot prevent the surgical option, but you might have to do this just to minimize the surgical intervention later. Like say, for example, the patient has 11 mm reverse overjet. You want to at least bring it down so that at least, your amount of, because every surgery has its own complication. Like if you're going to move the maxilla, say, just giving you for a rough example, say 10 millimeters, or, the mandible, say 10 millimeters, it's going to have a higher, relapse rate compared to moving it just within 3 to 4 millimeters. So even bringing down the surgical overload is possible with a phase 1 therapy in very, very severe class 3 patients. So the benefits would be potential for greater orthopedic change in a shorter span of time, prevention of periodontal recession and dental wear. All these are benefits of early treatment. Then you have earlier functional improvement. You can eliminate an anterior functional shift, like I mentioned, avoiding, a later chances for, greater surgical correction. And of course, it improves aesthetics and a positive behavior in the patient. Class 3 malocclusion, we know, worsens with age. So we'll have to keep that in mind. So treating them early is definitely much, much easier. So again, before you promise anything to the patients, you have to be very, very, very sure of what you're promising and what your outcome is going to be. Like I said, sometimes we perceive it, but how much is ground reality? We'll have to be sure ourselves first before we tell them. So just a little bit of controversies, just some articles. I can share this. So you can, if there are postgraduates in the group, you might benefit from this. There are controversial studies that say, contradicting early treatment. They say you just let the patient be and then treat them surgically later on. Otherwise, you're putting them through a lot of phases in treatment, and it eventually needs surgery. But then again, your case selection is very, very important. Like I said, in very severe class 3, you might still need a surgical correction, which the patient has to be aware of. But in mild to moderate to, in most of the cases, moderate class 3 patients, you can get away with your surgical treatment. There are a lot of studies supporting early treatment, just for you to know. I can share these. These are just basically summaries of the studies. I'm not going into this, but I just put this just in case anyone in the group is interested, can take a look at these. Stability factor with face mask therapy. There are studies that have shown good stability with face mask therapy, and they have positive overjet establishments. So once you establish a good overjet itself, that itself will prevent further relapse, right? So when you correct a class 3 and then you establish an overjet that is not ideal, that's where the problem is. Like you leave it in, say, an open bite or even an edge-to-edge bite, then there is a high tendency the mandible can, grow forward again, or there could be a relapse. But if you establish an ideal overjet, so that's the key. When we finish any form of orthopedic treatment or surgical treatment also, you need to establish a good ideal occlusion, which is very, very important. And that itself will prevent further from any of these relapses from happening. So do we have a crystal ball? Can we predict this orthopedic treatment from how exactly it's going to happen? Is it an ideal time to start? How much can I predict? How much of growth is there for the patient that I can predict? Okay, this much of orthopedic treatment I give, I will get this result. We don't have a crystal ball, but we have a few things that we can use like a crystal ball. For example, the growth rate, relative growth rate calculation. You could calculate how much of, what is the growth rate for the patient, how much could be. This is an article, you can go through the article in detail. It's a lot of steps. I can't cover everything in this, but at least I want to summarize it here. So at least you can go back and figure this out, and then you can actually calculate the growth rate percentage and to see, okay, if this patient has so much of growth potential, has only this much of growth potential, and treatment plan accordingly. So going on to the last part, which is a class 2 vertical maxillary excess. So like we dealt with class 2, we dealt with class 3. Now we're going to do class 1 with a vertical maxillary excess. This is what you obviously see in a mixed dentition. So we give something called a vertical maxillary splint. So if you see this patient, it's so obvious from his smile that he has this very gummy smile, and he has teeth, his entire teeth. Of course, in all children, the teeth will be, but you will see so much of a gum show, right? And then we had that doubt when we clinically evaluated him. So we did our cephalometric analysis. When we did the cephalometric analysis, we saw a vertical maxillary excess in him. So he's a class 1, ideal class 1. See, you can't do this in a class 2 or a class 3, right? Because there are so many other factors that you have to address. In a class 2, obviously, if it's a vertical maxillary excess, you're going to address it, hypal headgear, right? So in a class 1 with a vertical maxillary excess, you will give something called a splint. So what you do is you splint the entire maxillary arch, and then you put him on a headgear, right? So this will not have any other costs. Just one second. So sorry. I'm so sorry for this one. So because of that, so we give this maxillary splint, and we hold the maxilla upwards. So that way it will have an intrusive component of force, and it will prevent further downward displacement of the maxilla. So that's what we do in cases of class 1 with a vertical maxillary excess. So this is just a summary of orthodontic surgery in children. So now this concept is practiced in a lot of Asian countries, where they see children early on with a very evident skeletal problem, like say class 3. Most of the time it's class 3. And we always wonder, right? Like, can we actually do surgery in children? But they have shown a lot of literature and cases where the surgery is done early on. The only drawback with this is they might have to do a second surgery later. But the reason why they do this surgery early on is basically to improve the psychological well-being of the child, and also the quality of life for the child. I'll show you some articles. So there are a lot of articles where you've seen, especially class 3. Class 2, the psychological disturbance is not much compared to class 3, but in class 3, it really disturbs the children. their ability to perform in schools and their grades get affected, their mental wellness gets affected. So because of all this, they have done a lot of research in this area. And also the factor that the tongue plays a very, very important role in these cases. So when they address surgery early on, the amount of pressure from the tongue muscle, once the tongue is normalized in position, that itself has a very, very good effect on the teeth and all the other facial structures. So during growth, when this happens, all that functional components that actually work around soft tissue growth is also enhanced and has a very, very positive impact on the child. So you can go through those articles that they do have a questionnaire, and so this girl that I showed you, the class 3 patient, we actually saw her at 14 years. So we started her pre-orthodontic treatment in 14, and we performed the surgery at 16 years. And even so, usually they say 18, right, when growth completes, but we actually performed the surgery at 16, and we did her post treatment. So by the time we finished her, she was almost 17 and a half. So these articles that I showed you, they actually perform even at 12, 13 years of age. They do a pre-ortho, then they do the surgery at like around 13, 14, and then they follow them up. And they have some very nice follow-ups for about 10 years and 12 years, where you see in very small percentage of patients, there was a requirement to do a second or redo the surgery. But in most patients, it benefited the patient a lot. So I know the only thing constraint would be the financial constraint, if at all they require a second surgery. But I think these patients benefit a lot out of it, especially severe class 3s, in terms of quality of life and psychological impact on the child. So that's her again. So she was 14, and then we did pre-surgical. And then by the time she got here, she was about 16 and a half. This was just post surgery. So the limitations would be you need a patient's consent in case they require a second surgery. Most of the time they won't, but if you see these articles, there's a very small percentage when they do require. We have to weigh the risk-benefit ratio for the child, and then patient's expectations, obviously. So that has to be met. So apart from myofunctional therapy and the regular orthopedic treatment, of course, the trainers are the other way where we can manipulate the masticatory muscles and try to train them for better growth and better sagittal growth as well. So now there is also this ALF therapy, which they use an LG alloy wire, and then they actually try to bring the mandible, or rather they relieve the occlusal interferences. Like I said, functional retrusion could be a cause, right? They relieve that and they try to bring the mandible forward with this. This is not very popular these days, but of course, trainers are getting very, very popular these days. A lot of companies have come up with their own trainers. So any form of muscle exercise, training the muscles, to allow the mandible to burrow forward will definitely help. The only, again, pace selection is very, very important. The only time when this might not be conducive is when they have a genetic issue with mandibular growth. So there is a percentage of patients where genetically the mandible is short. Okay, so in those patients are the only ones who will not benefit out of these treatment modalities. But in majority of the patients where it's a functional retrusion, it's a tongue issue, or it is a problem with occlusal interferences, or like the case I showed you with the lip trap, once these interferences are relieved, then the mandible will automatically catch up. So in these patients, all these trainers or aligners will also benefit in terms of mandibular growth. So this is the wire that they use in the ALF therapy. So myofunctional therapy not only benefits just bringing the mandible forward and correction of teeth and profile, but it also plays a very, very important aspect in sleep apnea, obstructive sleep apnea. It opens the airway. In most of these patients, you could do an airway analysis. Actually, airway analysis is very, you don't even have to subject the patient to another radiograph, right? Like just on the CEF, an airway and a basic airway analysis can be performed. And this in turn, you will see there are studies that show pre-myofunctional and post-myofunctional therapy in terms of airway, how much of airway has improved. And this also improves quality of life, patients' mouth breathing habits corrected, and then it improves their breathing. These patients have a tendency to go into asthma and those issues later on. All of this could be corrected, and it could be prevented, I would say, once this therapy is successfully carried out. So airway is something that you can look for in a patient pre-treatment and post-treatment, that you will have an idea, so you can educate your other patients further on. Lingual granuloplasty is what I wanted to mention. Like I said, it's catching up in a big way in the other side of the world. So this one is where they relieve. So this is it's not just the lingual frenectomy that we do, right? So what they do is they actually go way deeper in the floor of the mouth and relieve the muscles and the frenum attachment. They technically loosen the tongue further. Of course, they have a set of diagnosis for it, and you have to fall into all of those criteria. And that itself allows any form of restriction to be relieved. The mandible slides forward, the tongue. In fact, this has been done in adults, not just in children, right? So there's not much literature on children, but in adults, they do it in a big way. There is this Breath Institute in Los Angeles, which they do a lot of studies on this. And if you go to their website and see their literature and articles, you will see how patients actually benefit from this. This is a very beautiful area to work on. I am actually working on this area right now, but it is a huge domain to explore. There's not much work done from the dental aspect on this, especially in children. And this could be a game changer in terms of myofunctional therapy in the future. So the take-home message would be, we address the maxilla in early mixed dentition with headgears for class 2 and class 3. In class 3, it's reverse. In class 2, it's your high pull, combi pull, or low pull headgear. For mandible, you address it in late mixed dentition because you want to target pubertal for class 2 and with functional appliances, and delay treatment for class 3, purely mandibular problem. So if it is a pure mandibular problem, you just have to tell the patient they have to go through some form of surgical correction and corrective orthodontics and permanent dentition, because there's very little that we can do in the mixed dentition stage for a pure mandibular prognatism. And remember, the diagnosis is key, and timely intervention is the most important when we are talking about myofunctional therapy and orthopedic correction. So it's open for discussion now. If there's anything, please excuse me for the interruptions. I couldn't avoid it. So
good morning, ma'am. Yeah, I have one query. In your opinion, what is the best treatment you can give for anterior crossbite in an 18-year-old baby?
I heard 18-year-old. Sorry?
18 months, 1.5 years.
Yeah.
Anterior crossbite.
So 18 months.
Once, yes.
Okay. So, like I said, see, there are some offshoot studies and articles that come up where they do some form of treatment in primary dentition, but it's not an established treatment protocol as such. Like, if you see evidence-based dentistry, right? So, according to that, you treat it only at 6, but then you have to counsel the patients and motivate them and tell them what they are looking for, right? Because at 18 months you first cannot even establish whether it would be a skeletal or a dental class 3. So you cannot really tell the patient you can only tell them these are the possibilities, this is what your treatment protocol could be, and you'll have to come in for follow-ups. But having said that, there has been some studies done with early treatment. They are trying some kind of, like, I wouldn't say fetal molding. Fetal molding is way early, but then something like that. But it's not been established yet. There's not enough data to support it. So I personally would still stick to the, conventional protocol of following them up and then seeing them at 5, 6, and then further treatment until I'm, convinced with the data that we have for early treatment, meaning early treatment as early as primary dentition, I mean.
Okay, ma'am. Thank you. Is it not going to interfere with the transverse growth of the child?
So
if you wait till 6 years.
No, so that is the thing. That is why we have to see them by 5, 6, because you still have a lot of transverse growth that is left, right? If you're going to leave them and see them at 8, 9, 10, we've already lost the transverse growth. So that's our concern. That's why you will have to follow them up and see them by 5, 5.5, and then start treatment by 6.
Okay, thank you, ma'am.
Yeah. And you also need your permanent teeth to actually start off with active force modulation, right? Like, yes, you do have patients where you put a 2x4 appliance, correct the anterior crossbite, even in primary dentition before 5 years. But as I mentioned, we need enough evidence to support it. So I can mention it, you can try them in a few patients, no harm, but then in a platform, if I'm going to suggest it, then there should be enough evidence to support it. Have I answered that question?
Yes, ma'am. Thank you. Definitely.
Yeah.
Doctor,
Good morning, ma'am.
you had some questions. Dr. Rajesh, can you hear me? Dr. Rajesh. Meera, can you hear me?
Yes, I can hear you. Dr. Meera, I would like to ask you.
Yes.
Meera, kekkuda?
So there's a lot of disturbance. I can hear you, Sharat, I can hear you.
Can you hear me?
I can hear you.
Dr. Meera, in your experience, in cases of crossbites or pseudo class 3s, being more habitual, would you recommend if we correct those habits in the primary dentition, would they be of help?
It would. The only issue would be is with regards to patient compliance, right? Like correcting a habit in primary dentition. One of the main reasons, see, any habit, it can be corrected, but then it should not have a psychological impact on the child. One second. So it should not have a psychological impact on the child, and it should, second thing, it should not, the child should be motivated enough to understand that they might have to change the habit. So these are the only two concerns why we actually address to the habits after 5 years. But like you said, if it is a pseudo class 3 is most of the time comes because of occlusal interference than a habit per se, right? It could happen, but I'm saying in most times it's because of an occlusal interference. Now, again, to correct the occlusal interference, like there are articles again who correct this early on, but how much can you achieve by treating a child below 5 years to correct this is still questionable. So we'll have to work on it more in that area to see and have more evidence to suggest a protocol as such. Like we can't come up like in mixed dentition, we have a protocol, right? Like you see a functional shift, you see, you do this. But in a primary dentition, we don't have an established protocol yet. So unless that comes, I cannot say, okay, it is doable. I'm not saying no, there's nothing that it cannot be done, but we'll have to figure it out ourselves. There's no established protocol to follow.
Could this be a call to the pediatric community, dental community to gather data?
Yeah, that's like I said, there are a lot of areas in pediatric orthodontics that needs to be researched.
Protocols can be.
Yeah.
Another issue, you talked about the early mixed dentition for say a maxillary deficiency. How much time would you prefer in a day that a child should wear the appliance, the myofunctional appliance, in early mixed dentition?
You're talking about functional appliance, right?
Yes, yes. Say for in a class 2 where we have a maxillary deficiency also. So if you give an appliance, how many hours in a day should a child wear that?
So the ideal is as long as they can, right? So with a headgear, we do have concepts like 12 hours wear and stuff, but with a functional appliance, we say as long as they can. So now the only thing is, it depends on what appliance you give them. So if you're going to give them a twin block, or if they are on a fixed functional appliance, which we will discuss in the next session, it is technically 24 hours wear. They take it off. I mean, if it's a twin block, they take it out while eating or brushing. And if it is a herbs like a forces or any fixed functional appliance, it's going to be in the mouth all the time. So the effect is more. But if you're going to put them on, say, an activator or a bionator, which is not a, it's a monoblock, right? So then what happens, they will have to take it off, on and off, so the effect is going to be lesser compared to a full-time wear. So the ideal would be a full-time wear as much as possible.
Thank you, Dr. Meera.
Yeah.
Thank you.
Any other doubts? Was it clear? Like, is there any part of the presentation that I know there was a lot of disturbance with my kids. I'm so sorry for that. But if there's any part that you want me to explain again, I can.
Meera, can you hear me now?
Yes, sir, I can hear you. I can hear you.
I'm not able to hear actually.
You can't hear me?
Yeah, can you?
I can hear you, sir.
Okay. Just give me a second.
Yeah.
Okay. Just give me a second. Okay. Yeah. Meera, it was a pleasure hearing you as usual. But there are a couple of quick questions I wanted to ask you. There are questions which were asked in the YouTube as well.
Okay.
I think we had almost more than 200 people listening to you because lots of webinars are happening across the country, and at least 100 to 200 people is a normal strength which we see these days. But 200 people probably it's because of the topic. But I'm sure that after listening to you, I think you're going to be more famous not only in Canada but in India also. I know that you're already famous, but still, I'm sure everybody enjoys listening to you always because I've known you from your undergraduate days, but I know that you're very organized, meticulous, and I think you had words of praise and appreciation from Dr. Rajesh also, because you are taking care of your child as well, promising us to give this lecture. I think I need to tell the audience that he's actually leaving to Canada in a couple of days. Then we forced to deliver this lecture and share her experience here. There was one question which I specifically wanted to ask you because as pediatric dentists, our topic of discussion is always on mixed dentition. For us, early mixed dentition would mean 6 to 9 years, and 9 to 12 years is our late mixed dentition. Right. So I got 9 out of 10 questions right, except that question on myofunctional therapy, which I didn't know whether I should write early mixed dentition or late mixed dentition, because certain things would happen probably at 10 years, and then you would say certain things would be better in the little early stages. So how do you define that early mixed dentition and late mixed dentition in terms of orthodontist? Or because 53% of people have actually answered that as early mixed dentition. And I think the answer which you have given is probably late mixed dentition. But even in your lecture, we heard that certain things you said by 10 years of age. And then you said, sir, in maxilla, you can probably do it 10 or a little ahead. So 10 or a little ahead would still, for us, being 9 years would be early mixed dentition. So
I understand.
Is there a question bias in the question we asked, or what is your take on it?
Let me explain this, sir. So when I say early and late, it's not by definition, sir. So there are a couple of factors that we consider, right? Like you're going to do the CEF. I'm going to add that. I have that in my next presentation. Actually, we do the CVMI index to see the growth stage. At what stage is the patient in? So in that also, I would be telling you, like, C2, you do this, C3, you do this. We have a tabular column in that presentation. So early and late is just for a simple understanding, sir. So like, according to us, early is like 6 to 8, and 8 and above is late mixed dentition. That's what we consider. Even there, in the West, that's pretty much the timing we consider. But again, it is not a pinpoint. Okay, the patient is 8 years. We can't pinpoint an age group like that. So when I say if the sutures are interdigitating at 10, we can't treat the patient at 9.5 because we only have 6 months to play with, right? So that is why I had the slides where I mentioned saying just prior to pubertal growth spurt. So now if the ideal time to address is pubertal growth spurt, we're not going to start at pubertal growth spurt, which is like 8-9 years in girls, right? So you're going to address ahead of time, right? Like you're going to do it, say you start at 8 years, and then, by 10, you're going to achieve your maximum outcome, right? So you always address it early on, a few months at least earlier than the actual time. Now, if the sutures are completing at 10, there's no way you start at 9. You have to go as early as possible, because the earlier you go, like say at 6 years and 7 years, you have more pliable maxilla to work with. If you go towards the sutures digitating, like say at 10, it closes. According to Melson, 10, the sutures have started interdigitating. So there's nothing you can do after that, according to him. So, but studies have shown at 12 and 13 years, they have done some amount of rapid palatal expansion. But the ideal would be, so if I want to summarize this, the ideal time to address the maxilla will be 6 years, max 7 years, right? Whether boys or girls, I'm saying. Girls, even more careful we have to be. In girls, in class 2, like if you're going to address the mandible, then you start by 8 to get the patient tuned in, especially in girls, tuned in and, ready to wear the functional appliance. And by 8.5, 9, they are already wearing it full time. So you get the maximum out of the treatment.
So if I have to rephrase that statement, does it mean that myofunctional therapy should be started in early mixed dentition rather than late mixed dentition?
So
because the question was
8 is early, sir, according to Pedo. 8.5 is early. I would not even say 8. We can even do it at 8.5, 9. So I think it's still considered late mixed dentition, no, sir.
Okay.
Because if we phrase it as early, then people are going to start at 6, 7, which is too early. You'll end up having a burnout, right? So we are also good starting at 9. There's no harm starting at 9. We say 8, 8.5, 9. It's like a range because you don't know when you see the patient. But the ideal time is at pubertal spurt. So when I say early, it's way too early, and then we end up having a burnout.
And there was another question. You were saying that we don't use chin cups much, right? And when I did my undergraduation, and then I was just entering my PG about 25 years back, 20 plus years, we could see a lot of chin cup being worn those days. And now there's a question asked in YouTube by one of the postgraduate students. How would you decide between giving a face mask and a chin cup? Would you really I don't understand. I don't know why they asked that question, but they will not be able to express their question here because it's on YouTube there. So,
Let me explain that. Maybe it might address the question. Face mask therapy has a chin cup component. I think I mentioned it in the lecture. Has a chin cup component, but it has no active force on it. It's more of an anchorage. Like, you have a component here on the forehead and on the chin just for anchor support, right? It doesn't have an active force being applied on it. So the face mask therapy basically is to bring the maxilla forward. Like I said, in most of these class 3 patients, it's the maxilla that's problematic more than the mandible. Most of the time, like there's an article in the lecture, I would have even mentioned the article under, which shows that most of the skeletal class 3s is a maxillary deficient component more than with a very slight mandibular component or a normal mandible. So technically, we have to only address the maxilla. That is why we put the reverse full headgear and we just hold the mandible and the forehead. And it's anchorage support also, and also it holds the mandible, right? Chin cup, we really don't give. That's why I said if it is a true mandibular problem in a skeletal class 3, we do surgery in adulthood. Like we tell the patient there's nothing much we can do right now, just leave it and we'll address to it as a surgical correction with orthodontic treatment at 18 years or 16 years. There's a lot of studies now where they do it a little early on. So chin cup is only to address a mandibular problem in a mixed dentition phase, which is not really practiced these days. So there is no question of choosing between face mask therapy and a chin cup, because face mask is addressing the maxilla. So if it is a class 3, in simple words, if it is a class 3 with a maxillary problem, you do face mask therapy in mixed dentition and do phase 2 later on. If it is a mandibular problem in a class 3, in mixed dentition, we don't do anything. We address to it in adulthood with surgical treatment.
Can you come again for that last part?
If it is a true mandibular problem, there's no maxillary component. There's only a prognatic maxilla in a class 3. In mixed dentition, there's nothing we can do. We just wait and do ortho and orthognatic surgery in teenage or when growth completes.
I'll just take 2 quick questions because there are some questions on cephalometric analysis, some on myobraces and trainers. I thought we would take it after Jiva's lecture and your second lecture. Okay. One question was asked on for a patient with skeletal class 2 tendency and with a dental end-on.
Okay.
Okay. What should be the treatment plan? Because I think the students are confused between class 1, class 2 in molar relation, and if it's a skeletal class 2 with an end-on, right? Okay. Okay. But they also mentioned if it is a bimax as well. But does it have a skeletal class 2 with a bimax and an end-on?
No.
It's not possible, right?
So if it's a bimax, why do we call it bimaxillate protrusion? It's a class 1. It's a class 1 skeletal base. The maxilla and mandible are in normal proportion to each other, but both are forwardly placed to the true vertical. Okay. So that's why we call it bimax. So it's a class 1, but both the jaws are forwardly placed.
When you say class 1, it's class 1 molar, right?
Class 1 molar is class 1 skeletal. So what's class 1 skeletal is your maxilla is 2 to 4 mm ahead of mandible. So if you do your cephalometric analysis, so in this case, maxilla is 2 to 4 mm only ahead of mandible. So it is normal. If you see maxilla to mandible, it's a normal ratio. But if you see to the face, it's forwardly positioned. Okay. Both are forward. So that's why we call it a bimaxillary protrusion. Both the jaws, bidental protrusion, ideally we should say. Yeah. Both the jaws are protruded. That is a completely different entity that I think I spoke about it in the second or third slide. You don't really see that in mixed dentition. You see it in adulthood where both are protruded. So then what you do is you only correct it surgically if you want, or you can do just dental correction by, correcting the proclination. But surgical also is possible. You can do an, anterior AMO and, BSSO to just push both the jaws backward in adulthood.
but in class 1 skeletal, the only factor that we can address to in mixed dentition will be this vertical maxillary excess, which I spoke about. The other question someone's asked is if you see an edge to edge in a class 2 skeletal. They're asking how will you do a functional, I think, because you can't bring it forward, right? Like
what's your treatment plan? What's the treatment plan?
Yeah, so in that case, sir, we have to evaluate again. If it is a headgear, you can still give, because you're not going to have effective retroclination of anteriors. You can maintain that and just give a headgear. But the only issue will be to put a functional appliance, because you cannot bring the jaw forward. You'll end up in a crossbite, right? So in those cases, this is very similar to a class 2 division 2. If somebody has a doubt, in a div 2 also, you cannot bring the jaw forward with a functional appliance. It's going to be restricted. In these cases, the ideal will be fixed functional appliance, because in a fixed functional appliance, you can do dental and sagittal correction at the same time. So you can address to the proclination factor, achieve a good overjet, and then bring the jaw forward. Sorry, sir.
I think we will give you another 1.5 hours break to take care of your child. We'll trouble you that one question was asked on skeletal class 3. I think we will do that when you come back. Is that okay? There's one last question.
Sorry, I had to stop you. Did I answer the earlier question?
Yeah, that's done. Only one more question. Do you want to take it now or after this?
I can take it, please.
Yeah. There are 2 questions asked on skeletal class 3. I'm just going to combine both. 11-year-old child, skeletal class 3, but a vertical grower. Okay. The same part is class 3 skeletal malocclusion, vertical grower. Okay. Can we advise reverse pull headgear as would even worsen the vertical height of the patient?
Yeah. So that's a very good point, because reverse pull headgear creates a cant, like when you do. But there are ways to work around the cant. There are a lot of articles that say how to prevent this vertical open bite from taking place. So what they do, the position of the elastics, and also we splint the entire maxillary component. Like you said, like I showed you in the picture, there was a picture where only the molar and the premolar are splinted, and then they give a face bow therapy. In that, the cant is more. But when you splint the entire maxilla and make it like one component, the amount of cant is minimized. So those are all ways that we can work around even in a vertical grower. There are ways to do it, sir. So I can't hear you now.
Thank you, Meera. We will take a break of this particular session.
Okay.
Meaning we will have Dr. Geeta Priya to continue this, and we will meet you again for the second lecture after a small break for you.
Okay.
Right?
Okay,
not
sure.
for us, a break for you. And thank you so much again, Meera.
Thank you, sir. Thank you. I will answer any other questions when I come back.
Yeah. I have some questions on myobraces, trainers, myofunctional therapy, someone's cephalometric analysis. I've asked Jiva to touch on certain things.
Okay.
Once we complete that lecture and when you come back for the second, then we will ask the question.
For sure. Okay.
Thank you so much, Meera.
Thank you so much. Thank you, everyone. Thank you.
Good morning. I'm Dr. Yogesh, Reader in the Department of Orthodontics, KSR Institute of Dental Science. It's an honor to introduce the second speaker of this session. It's Dr. Jeevarathan. He completed his BDS from Savita Dental College, his Masters from Meenakshi Ammal Dental College. He's in the field of academics, guiding UGs and PGs, and at present working as a professor in the Department of Pediatric and Preventive Dentistry at Sri Balaji Dental College and Hospital. He has proposed a classification for talus cusp and dense invaginators. He has contributed 2 chapters to the book Pediatric Dentistry, Principles and Practices by Elsewhere Publications. He has given numerous guest lectures in various conferences and CDE programs. He is one of the few people who use nitrous oxide oxygen sedation in his day-to-day practice, and is also associated with Indian Dental Sedation Academy, who provide training to students for the sedation program. Welcome you, sir.
YouTube close பண்ணேன். ஜீவா, can you hear me? கேக்குதா ஜீவா? ஜீவா, can you hear me? நீ ஓடி போய் Jiva, can you hear me, Jiva? Jiva?
Hello.
Now we can hear you. Yeah.
Okay.
Okay.
Now it's audible. Okay, fine.
Slide share, screen share.
Fine. Is it moving?
No, Jiva, actually I can't see I can see the first slide and I can see the second, third slide also. Start the first slide also.
Now are you able to see the second slide?
No, it is not in the slideshow mode.
It's still in the first slide. See, what you do is actually sometimes if it happens, நீங்க close பண்ணிட்டு
I again share.
Screen share la first open பண்ணிருங்க.
Now?
Yeah.
Perfect.
Is it moving?
Yeah,
yes,
now
yes.
It's moving. Perfect. Yeah.
Thank you.
Over to you, Jiva.
Very good morning. It's almost going to be a good afternoon. And it's a wonderful lecture by Dr. Meera. Is it audible, Sharath?
Yes. Clear.
Okay. So this is my institution where I work, Sri Balaji Dental College, and where I work as a professor in the Department of Orthodontics. And anybody who comes to Chennai are welcome to the department. And I would like to thank the management of KSR Dental College, the Dean Dr. Sharath, and the pediatric team headed by Dr. Keetha Priya for giving me another opportunity to be part of this open secret, pediatric orthodontics. So this is a very common clinical scenario or a situation we experience. That is a child with a parent, probably in the age of 6 to 9 years, entering into the dental clinic, or it could be your department, and that they would have identified a problem in their child, new tooth which is erupting. So the most common thing they ask is, they would say that there is a lingually placed mandibular incisors, or they might identify the minimal alignment issues on the lower anterior teeth, or they will say that one of the permanent incisors have not come. They have lost 4 incisors, but only 3 have been replaced. But the parent will be very much concerned about the alignment issues, even though the child has other problems like a grossly destructed dental caries. So their aim will be only on the alignment issues at the age once the child enters the early mixed dentition part, that is between the 6 to 9. And when it comes to the upper anteriors, it is more alarming to them. If you're going to see a teeth which is very irregularly arranged or crookedly placed, or there is too much of space or too much of irregularity, they just walk into the dental practice and they have these 3 questions within us. They will ask us, doctor, can you analyze the child? The existing dentition, the earlier dentition, it was all properly aligned. There was no irregularity. And now the present one which comes, they are not properly aligned. They are almost irregular. Can you just predict what is happening within my child's mouth and tell how is going to be the future permanent dentition? That is, they want that if the child has to undergo any preventive regimen so that we can avoid any drastic alignment issues, because they, either the parent, the father or the mother, they would have undergone some management. They would have undergone an orthodontic treatment for almost 1.5 years, which they don't want their kid to undertake it. So they will be a little precautious. They want any preventive things can be done for my kid so that he or she doesn't land up into this, the irregular or malaligned teeth problem. So what they basically want us to tell them is, we have to predict and tell them whether their child will be a candidate where he or she might land up in what we call it as a tooth size and an arch length discrepancy. So more precisely, we have to say it is an arch circumference discrepancy. That is a tooth size and an arch circumference discrepancy. So the only tool what we have as a pediatric dentist at that moment, this tool is nothing but your mixed dentition analysis. So this is the only tool which is proven. It is more accurate. It is more clinical and practical tool which you can apply it onto those situations and find out whether the child is going to land up in this tooth size and an arch circumference discrepancy as they grow into the later period of their life. So as per the definitions, if you're going to see that there is no proper definition for a mixed dentition analysis. If you're going to see, it is that the various authors have suggested different techniques to determine the space available in the dental cast and the space required for the permanent dentition when they erupt within the patient's mouth. They call that as a mixed dentition analysis. There are numerous methods and analysis have been proposed, and so you don't have a correct definition for a mixed dentition analysis. So the main objective of a mixed dentition analysis is that you have to find out that is there enough space for your unerupted permanent teeth which is going to come and replace your early primary teeth. So that is the what we have to use or find out using this mixed dentition analysis. Basically, that means you need to find out what is the space available in your dental cast, and you have to compare that space available, what could be the space which will be required for the newly erupted teeth, which you have to choose it from any of the analysis what you have. You have numerous analysis. So the indications for mixed dentition analysis, according to Nanda in 1983, if you go, it is a premature loss of primary canine, especially a unilateral premature loss of my primary canine, either in your maxilla or in the mandible, a rotation or blocking of a permanent teeth. One incisors have not erupted. That means the 4 mandibular incisors would have been exfoliated, but only 3 permanent incisors would have come. An ectopic eruption of a permanent first molar, sometimes it get lost, or it could have caused early resorption of your second primary molar or even exfoliation. Distal terminal plane relationships and any cross bites, either it's anterior or posterior cross bites, then those situations you need to go on for a mixed dentition analysis. The principles according to Fields and Prophet that they should have an erupted first permanent molar and all your permanent mandibular incisors should be erupted. So this is the one which is mandatory. That is, permanent first molars, both in your maxilla and your mandible, should be erected. And all the 4 permanent mandibular incisors should be present within the oral cavity. Whether they are rotated, it doesn't matter, but they should be always erupted. And you should have all the succedaneous teeth which are present. So you must take a radiograph and confirm whether all the other succedaneous teeth are present in the OPG. And the principle is basically based on, there is always a size relationship which exists between your unerupted teeth and the erupted primary teeth. So there is a size differential also, which we all know that the mesiodistal width or the combined mesiodistal width of your canine, first primary and a second primary molar, when you compare with the combined mesiodistal width of your permanent canine premolars, it is always going to be smaller. We call that as your leeway space of Nance, which is around 1.7 millimeter in mandible and 0.9 millimeter in your maxilla. So this is the principle which we are going to keep in your mind when you're going to do a mixed dentition analysis, that you should have an erupted permanent molars and all the 4 mandibular incisors should be erupted. Why? You always choose mandibular incisors to predict even your space availability in the maxilla, because it is the early tooth, the first tooth that erupts in the mixed dentition, and it is present in an easily accessible area where can you easily measure it. And it is always directly in the midst of your space management problems. Whether you have a space dentition or a crowded dentition, you will first, it will be most probably it will be seen in your lower anterior region. And the chances of congenital missing or malformations, morphological malformations of related to your mandibular incisors are very less. And the most important thing is there is the coefficient correlation between the sum of the mandibular incisors to the mandibular mesiodistal width of the combined width of your canine and first premolars and second premolars are higher. There is a higher correlation coefficient is present when compared to any of the other teeth which are present in the oral cavity. So that is why always your mandibular incisors are to be there or should be there when you wanted to do a mixed dentition analysis. Why we don't choose maxillary incisors? Because you have a much variability in the size morphologically, because you tend to have peg laterals. A defect could happen because of trauma to your permanent or primary incisors. Another one thing is the correlation coefficient when you combine the mesial width of your maxillary incisors with the unerupted canine and premolars, there is a lesser correlation. So lower incisors, they show more higher correlation. So always we use lower incisors to predict even the size of your upper as well as your lower posterior unerupted teeth. Coming on to the types of mixed dentition analysis. Mixed dentition analysis, they use certain analysis, use a prediction table. Under that, we have Moyers, Tanaka Johnston, and Ballard and Wiley. A truly radiographic analysis are case Nance and Hukaba analysis. Hukaba analysis is not an actual mixed dentition analysis, but still it will be useful. A radiograph and a prediction table. An analysis which use both radiographs and prediction table is your Hickson and Oldfather, Stally and Kerber. That is a modified Hickson and Oldfather analysis. Before we go into how to do a mixed dentition analysis, we should know certain terminologies which we commonly use whenever we talk the cast. The most important thing is your arch perimeter. That is, it is the amount of space available from the mesial surface of your first mandibular molar or your maxillary molars, which goes all around your arch and ends on the mesial surface of the other side of your mandibular or your maxillary first permanent molars. That circumferential area, we call it as an arch circumference or arch perimeter. Other than that, we commonly use the term what is called as an arch length. Arch length is nothing but it's the total vertical length which we come when it's a length in the midline of your cast. When a vertical line is drawn from the mesial surface, a line has to be drawn. The midline, what is the length you have, you call it as the arch length. So arch perimeter is the most important thing which we will be using whenever we do a mixed dentition analysis. The other armamentariums which are required when you want to do a mixed dentition analysis, you need a dental cast of both the arches, upper and lower, a good dental cast. Bowley gauge or a divider needs to be there. Millimeter ruler, especially a metal one. And periapical radiographs, a good periapical radiographs or even a biping radiographs which are taken using your holders would be ideal. And based on the type of analysis what you're going to use, whether if you're going to rely only on a radiograph or if you're going to go for a probability chart analysis, that chart has to be available. These are some of the armamentarium which has to be there. So first we will see how to evaluate or estimate the available space in the cast. The step one when you want to estimate the available space in the cast is first step what you need to do is have to mark the midline in your maxillary cast. But you have to just mark the midline. It should be the intermaxillary suture has to be marked. That is on the palatal surface. You have to mark the first line. That will give you the skeletal midline, and you need to transfer that skeletal midline onto the labial side of the cast, and that we call it as their dental midline. So here we have to be very careful that this dental midline which has been transferred from the intermaxillary suture. So you identifying the intermaxillary suture is very common. You have the mid-palatine raphe, you have the incisive papilla there. You can, along that, you will be able to connect it and transfer that midline onto the labial side of your maxillary cast, and that will be your dental midline. And this can coincide with your labial frenum. Sometimes it might not coincide with your labial frenum. Once this line is transferred onto the labial aspect, you keep the mandibular cast in the perfect occlusion and transfer that line from the maxillary cast to the mandibular cast. So this is how you have to mark the midline of both maxilla and mandible. This is the first step which we have to do it in when you do a mixed dentition analysis. You cannot directly take a lower cast, mark the midline between the two central incisors. It might not be the correct midline. So the ideal way to identify the midline in any cast is you have to start from the maxillary cast and you will end up in the mandibular cast. So I'll just show you. This is how it has to be done. So if you're going to take this cast, this is an ideal cast where you can do a mixed dentition analysis because you have an anterior crossbite in relation to 1-1, and there is also a crossbite in relation to 5-3, and you can see mild amount of crowding or irregularity in your lower arch. There is excess space is present in your lower arch. The first thing you have to do is mark the midline, that is your skeletal midline on the maxillary cast, and that line has to be transferred onto the maxillary labial side. And after you place the lower arch, then you keep the cast and transfer that line. That is what your dental midline. This is the first step which we need to do it in a mixed dentition analysis. Then once it is done, then you're going to calculate the available space that you have to measure the mesiodistal width of your mandibular incisors. That is, you have to calculate the mesiodistal width for 4-1, 4-2, and 3-1 and 3-2. And I would prefer you doing it separately for each quadrant, because already if there is a midline and if you're going to take all four and if you're going to divide it by 2, sometimes if your measurements are not properly, then you will end up in discrepancy. So always everything has to be done perfect to each quadrant. So you add the mesiodistal width of 4-1 and 4-2, keep it separately. Add the mesiodistal width of 3-1 and 3-2, keep it separately, the total millimeters what you have got. And that, if you want to do it, you have to measure the mesiodistal width using your divider or your Bowley gauge, or you can use your vernier caliper. You have to measure the maximum mesiodistal width available at middle third of your incisors. And similarly, you have to start measuring the mesiodistal width of your maxillary incisors. The 1-1 and 1-2, you measure it, keep it separately, and 2-1 and 2-2, measure it, add it, and keep it separately. This will give you the mesiodistal width of the incisors of each quadrant on the for that patient. So this is how it has to be done. You have to measure it and the maximum width. Similarly, what we do, what you did in your mandibular cast. So once you have done it, now is to mark the sum of the mesiodistal width of central incisor, lateral incisor on each side. So that you have to mark it from the midline. So already you know the mesiodistal width of 4-1 and 4-2. How much it probably, if it is 11 or 12 mm, take it in the divider, place it on the L1 line, what you have marked as the midline, and to the corrective same quadrant, you mark the other line, that will be the L2 line. So you will have 2 L2 lines marked on each side of your cast. It will be on your mandibular cast, and similarly, you have to do it on the maxillary cast. So what you have to consider here is, if you have crowding, the crowding of mandibular incisors there, then probably your second line, the lateral second line, L2 line, might not coincide on the distal surface of the lateral incisors. You have to alleviate the crowding, and then you have to identify how much of space is available. So all this part has to be done meticulously. If you have crowding even in your maxillary cast, then you have to alleviate that crowding. So you have to properly calculate how much space is there. You have to leave out that space and mark the L2 line on the cast. So this is how it has to be cast. For this patient, if you're going to see L1, L2, the L2, if you see on the lower, the fourth quadrant, the L2 almost lies on the one-third, mesial one-third of the lower lateral incisors. Whereas if on the right side, if you're going to see, it almost goes onto the middle third of your primary canine. And similarly, if a maxillary cast, it goes, because you have to alleviate the crowding and you have to give sufficient space, align the incisors before you consider how much of space is still available for your unerupted canine and your premolars. Once this is done, next is to mark the mesial surface of the first permanent molars on the both the arches, that is both maxilla and mandible. That will be your L3 line. So you will have L3 lines, both two L3 lines on each cast. So you have to then, once you mark that L3 line, then you have to measure the space between your L2 and your L3 line on all your quadrants. That will give you the amount that is available on your maxillary cast for the unerupted canine and your premolars. So you have to calculate for each quadrant and make a note for each quadrant. So this is how you have to calculate your available space. And this L2, the space which is available, there's available space between your L2 and your L3 will, that is the available space you have it for your unerupted permanent canine and your premolars. So once you have done this, this completes your analysis or evaluation of available space on the cast. So this part is always common to what type of analysis you are going to choose, because always the available space you have to calculate only from the cast. The only certain areas where they will say that you can use a brass wire to completely measure the circumference is still you can do it if you're able to properly align it and get it. You have to stretch it then, and then you have to measure and check it off if you want to actual space. So this is another method we usually do it, but this is this very simplified method. This is how you need to do it. So that is, you have to start marking the midline on your maxillary cast, transfer that skeletal midline to the dental midline. That dental midline should coincide with the mandibular midline. Then from then you have to just calculating the individual mesiodistal width of the molars, incisors, and then align it, and you will ultimately find out how much of space you have available in the cast for the unerupted canines and premolars. Once this part is done, then you have to go for to calculate your required space. The required space you have to calculate only using your mixed dentition analysis. So you have numerous mixed dentition analysis that has been proposed. You have Hayes-Nance analysis in 1947, Ballard and Wiley in 1947, Hickson and Oldfather 1956, Moyes mixed dentition analysis in 1971. Then you have Tanaka-Johnston in 1974 and the revised Hickson and Oldfather analysis by Starley and Kerber in 1980. There are numerous analyses which are available, but each analysis has their own way of working on it. You have radiographic and prediction chart is required. Some analysis requires only your prediction chart. Some uses a combination of both. So the most commonly used mixed dentition analysis in your day-to-day scenario are your Moyes, your Tanaka-Johnston, and your Hickson and Oldfather are the most commonly used, because if you're going for the Hayes-Nance or the Ballard and Wiley, they are more related to a radiographs where you need to have radiographs for each and every side, where intraoral periapical radiographs of eye correct angulation has to be taken. There should not be overlap for all the four quadrants should be there. So these two analyses are not very commonly used, whereas the other analyses are very commonly used. Of that, the most commonly used analysis are your Moyes mixed dentition analysis and your Tanaka-Johnston mixed dentition analysis, which we call it as the shorter version of your Moyes mixed dentition analysis. So before we go into know a detail about each of your analysis, just we have to, I'll just tell you about a study design. How these analysis evolved, how they did this analysis is that they have selected an n number of patients who had a full set of permanent dentition. That is people who've been around 18 years or 19 years. So those people, full set of dentition cast is available with them. So what they did is they calculated the mesiodistal width of all the teeth which are present within them, and they have identified the mean mesiodistal width of your lower mandibular incisors, and they have identified the mesiodistal width of your erupted canine and premolars. And they found out what is the relationship which exists between the sum of the mesiodistal width of this with the sum of the mesiodistal width of the other unerupted or the erupted teeth, that is your canine and premolars. They found that what is the relation using your Pearson coefficient correlation. And Pearson coefficient correlation will just tell you how highly it is correlated. If you're going to have a negative value, it means that there is a lower correlation. And if you're going to get this value of 0, it means that it is by chance there is a correlation. And if you're going to have more of a positive value, more than, less than, or more than 0 and less than +1, it says that it has a higher correlation. So they have tried all the combinations and they found out that the mesiodistal width of your mandibular incisors, they give a higher correlation for the mesiodistal width of your erupted canines and premolars for both the upper and your lower arches. So they have found out this correlation, and with this correlation value, it usually represented by a value called R. R is equal to, it might be 0.625, it will be different for different type of analysis. So based on this R value, they went in for a simple linear regression equation identification where it is called as y is equal to a plus b into x, where y is your combined width of your 3, 4, 5, which is equivalent to a and b are constant values which are derived based on your coefficient regression values, and x will be your combined width of your mandibular incisors. So this simple linear regression equation is something which we would have studied when you want to convert the reading like your Fahrenheit into Celsius. So if you want to convert how much Fahrenheit into Celsius, you have a specific formula, F is equal to 1.2 C plus 32. So something like that. This linear regression equation is one which is commonly applied for all the mixed dentition analysis, where y is equal to a plus b into x, where this a and b are constant, which keeps changing to each and every analysis based on the regression value what they have achieved. And based on once they have reached this equation, then this equation what they have got for individual combinations, they have predicted either as a table or a chart, or it can be in a percentile way. And next, they try to validate this on doing it a longitudinal study on people following them from the mixed dentition period. They will apply it on when they are in the mixed dentition period, and those children will be followed on. And once their permanent canine and your premolars are erupted, they will find how is the correlation. So this is how the original mixed dentition analysis study have been done. So if anyone wants to do a mixed dentition analysis to in their local region, this is the methodology. You can try it and you can start working on your patient, but it will be a long-term study because calculation can be, previous cast can be done early. But when you want to do a longitudinal study, you should start seeing the child from 6 until they go on for 12 to 13 years. So at least 6 years or 7 years of a longitudinal study. So this is how a mixed dentition analysis is usually, this is the study design they have been done for most of the things. So we will go on to one analysis, 4 analysis we are going to go on it. The first is your Moyer's mixed dentition analysis. Here he used the linear regression analysis, the same formula where y is equal to a plus b into x, where he used the constant value is 9.23 and 0.55 for maxilla, and 7.82 and b is equal to 0.60. And this is the constant value he has used it, and he has proposed the different equations and different analysis, different readings have been obtained. And what he did this, he tabulated the various percentiles of this regression equations, and he presented this as a table, and he called this as the unified mixed dentition analysis. This analysis was only it is given only in his book, Moyer's book, textbook of orthodontics Moyer's, but it is not published anywhere in any of the articles. So this is how Moyer's mixed dentition analysis was done by Moyer's. So the armamentarium required for the cast estimation, you need dental cast of both the arches, you need Bowley gauge or a divider, millimeter ruler, and you need to have the probability chart which was given by Moyer's, and he gave 2 charts, one for the maxilla and mandible. Sorry, he gave 4 charts, maxilla and mandible for both the genders, boys separately and girls separately. So this is the chart which is given for the mandibular bicuspids and your cuspids for males and females, and this is the one which is given for the maxillary bicuspids and cuspid for males and females. So now the estimation of space of unerupted teeth, what we need to do, so you know the sum of the mesiodistal width of 3132, 4142, which you have done it in the class, you know how much millimeter is that. So you have to go to the chart, you have to select whether it is a male or a female, whether it is a maxilla or mandible, then you have to choose the 75th percentile, and you have to go what is the max reading what you have got under 75th percentile based on the mesiodistal of the sum of the 4 incisors. You have to check what could be the required space for the unerupted premolars and canines. So that you have to make a note of it. It has to be done estimated for the mandibular arch separately and maxillary arch separately. And what value they have given in the chart is for only 1 quadrant. So you have to use that quadrant and compare with the concerned quadrant how much space you had got it from the cast. So the difference is going to give you whether if it is going to be a positive value, you are on a safer side. That is, you have excess space. If it is going to be on a negative aspect, then there is the crowding chances are more severe. So this is how it has to be done. That is Moyer's mixed dentition analysis. He always chosen 75th percentile. Some people try to choose the 50th percentile. When we go for a 50th percentile, the chances what we are going to see the malocclusion problem is we are going to try to find out whether the child can have a crowding problem or the child can have a spacing issue. So always when you go slightly on a higher percentile, that is what Moyes is saying. If you are going for a 75th percentile, the chances of crowding, the severe problem is your crowding problem. So it will be better to take the 75th percentile. The advantages of this mixed dentition analysis are, especially our Moyers, it has a minimal systematic error and it has an equal reliability by the beginner or an expert. Whoever does it is easy to do it. It is not time consuming, no need of any special equipment or radiographs are needed. What you need is you should have a good dental cast. And it can be done on both the dental arches. The disadvantages, Moyers, where the sample in which Moyers did the study is unknown till yet. So, and probably it is most of it is a probability diagnosis, and they have found out that it is always going in for a slightly underestimation, and they found that this analysis doesn't take into consideration of your lower incisors, the angulation of your lower incisors on your mandible. And if you are going to have a sum of the mesiodistal width, the chart has been given only from 19.5 to 25.5. If you are going to have a smaller values or if you're going to have a higher values other than this Moyers mixed dentition analysis cannot be applied. So the next analysis is your Tanaka-Johnston analysis, which we call it as a Moyers shorter method of analysis. So here the armamentarium required is you need a dental cast of both the arches, Bowley gauge millimeter and a millimeter ruler. It is more simplified. It does not require any of your probability chart. But if you go back to see how this Tanaka-Johnston analysis was done, it was done on a Cleveland area population where they selected 506 patients. The main idea what they wanted is to validate what Moyes has already told them, because the sample in which Moyes did, we are not known of it. So they wanted to try Moyes analysis on this Cleveland population patient, and they found out they wanted to try whether this 75th percentile is suitable for this patient. So what they did is they similarly collected this 506 patients cast, maxillary width, mandibular width. They did the study what I've told you already, and they gave their own probability for this specific population. And this is what the chart given by Tanaka and Johnston for the Cleveland population. It is a Moyes chart for the Cleveland population. They have done it. And what they did is after this, they compared with the Moyes chart, and they found out that the Moyes chart and this chart is almost on the same thing. There is only marginal error. If you're going to see that Moyes in this second row, if you see Moyes, it is 21.2, whereas if they've done it as on the Cleveland population, it is 21.4. So if it is only a 0.1 or 0.2 millimeter of difference was found, and they found that this 75th percentile what Moyes has given is more apt even for equivalent population. But they don't want to say that they have just did only the same method what Moyes did. So what they did is, based on this approximation, they came out with a formula which aptly suitably says that the mesiodistal width is going to be set. So they gave this formula, that is, if you want to know the unerupted teeth of your mandible 3, 4, 5, what you need to add is the sum of the mandibular incisors by 2 plus 10.5. 10.5 had to be added to the sum of the mandibular width, that is by 2, half the estimated width. And similarly for the maxilla, it has to be your maxillary unerupted teeth is equal to sum of your mandibular incisors by 2 plus 11. So this is a constant value they found out, and this value almost correlated with the approximated value what you have got in the middle one. So, and this was the formula they have provided it, and it is, we call it as the shorter version of your Moyes analysis. Actually, they replicated the Moyes analysis on equivalent population, and instead of just saying that Moyes is good, they came out with this formula, and they said that this will be an ideal way, an easy way to calculate, and they just wanted to avoid the usability of a probability chart. We don't want anything else, and this is what their formula is. 1/2 of the mesiodistal width of your lower 4 incisors plus 10.5 will give you the estimated width of the unerupted mandibular canine and your premolars. Whereas if you're going to add 11 mm, we call it, then you will have the estimated width of your maxillary canine and premolars in one quadrant. The advantages, it is simple, easy, it is very less time consuming, and no, you don't need any prediction task. The disadvantage is it is done in a different race. It was done on the Northwestern Indian descendants. So this is what your Tanaka-Johnson mixed dentition analysis is. Next is your Hickson and Oldfather analysis, which was given in 1958. This is another commonly done mixed dentition analysis by us. The armamentarium, what you read is your dental cast, Bowley gauge or your divider, millimeter ruler in a metal, and you need to have a periapical radiographs for all the quadrants, especially if it is taken according to Hickson and Oldfather, it was taken on a long cone technique with a 16-inch one. So you need a periapical radiographs, but if you're going to have a biplane radiographs, it's also where you should be able to measure the mesiodistal width of your unerupted premolars. So this Hickson and Oldfather study was done in an Iowa area patients who have been involved as part of your facial growth study, where the requirement for this study was they should have the cast of that patient when they had your primary canine first and second deciduous molars, and they need the X-ray of the primary canine first and second deciduous molars along with the unerupted 3, 4, 5, and after the permanent tooth erupted, they had the cast of this 3, 4, 5. So all these data were available for these patients. So they had, and similarly, he had a few more patients to that. And most importantly, this Hickson and Oldfather can be done only for your mandibular arch, and it cannot be applied onto your maxillary arch. So what he did is he found out chances of, he derived many types of correlations. That is, he combined the cast with X-ray with that of the, and found out what are the different correlation correlation ratios what he has got. And he found out that when he combined the mesiodistal width of the unerupted premolars in the radiograph with the mesiodistal width of the erupted central and lateral incisors of that quadrant, they always gave a higher correlation value. The last 4 on the left table, that if you see, it gives 0.88, 0.87 correlation, where you could have a maximum correlation value of only 1. So based on this correlation value, what he thought, he proposed that Hickson and Oldfather, what is the actual proposed method is the sum of the mesiodistal width of your central and lateral incisors in a quadrant measured on the dental cast plus sum of the mesiodistal width of the first and second premolars of that quadrant measured in the radiograph. So that will give you a value, and take this prediction task, and you have to find out what could be the predicted value which will be required for the unerupted canine and your premolars in the quadrant. So based on this, he proposed, this is the methodology to do a Hickson and Oldfather analysis, and this can be done only in your mandibular arch, and this is how the correlation value went on. So estimation of space available, you have to sum the mesiodistal width of your 3132 or either 4142 and keep it separately, and you have to measure the sum of the mesiodistal width of the unerupted premolars in your periapical radiographs or your bite wing radiographs, and you have to add both of these things, and this value has to be compared on your probability chart where they will give you the estimated or the required space. So for each quadrant, then you know the available space and you know the required space, you have to differentiate, and if you're going to have a positive value, it means that there is excess space, it is safer, and if you're going to have a negative value, you have to anticipate crowding, you have to plan management regarding that. So next is the other study is your Starley and Kruber study. It is nothing but a modified way of your Hickson and Oldfather study, and the samples were same as the facial growth study, similar to the study done in Hickson and Oldfather, and they cross-validated that one on 53 Caucasians, and still this study can be only done on your mandibular arch, and they use the same formula, but they improved the prediction equation. What they did, and instead of just giving a prediction chart, they give a graph. The only difference is in a Starley and Gerber, it is based on a graphical representation, whereas in Hickson and Oldfather, it is a chart-wise distribution. So this completes the most major types of your mixed dentition analysis, or most commonly used mixed dentition analysis. And apart from that, if you're going to write it, if you're going to have a question related to mixed dentition analysis, there are numerous articles which have been published where a review have been done by Dr. Irwin in 1995. Most of the mixed dentition analysis are older studies. And another study done by Buamba in the year 2004, where mixed dentition meta-analysis and a validity and reliability of mixed dentition analysis, a systematic review by Nuj Lu in the year 2011, and a systematic analysis. And these are some of the articles which are available, which you can quote it when you're writing a question with the asked on mixed dentition analysis. And there are studies which have compared different types of mixed dentition analysis on a same group of people. These studies are very older studies. Kaplan in 1978, where he compared Hickson and Oldfather, Moyes and Tanaka Justin, and they would have come up with the better is your Hickson and Oldfather. And similarly, another study got done by Gardner, they would have done comparing Nance, Tanaka Johnston, Moyes, and Hickson and Oldfather. These are some of the studies where you can write it, but these are all very older studies, and you don't have any comparative studies recently done on any population. Applicability of Moyes mixed dentition analysis of Indian population. This is another study. We have few articles which are done on Indian population. They have come up with certain analysis studies done specifically on Indian children. And these are some of the articles which you can quote when you have been asked a question on that. And just for completion sake, you have certain analysis which you can do it only on primary dentition. If you're going to have a patients where you're going to do a band and loop space maintainer on a primary cast or a primary dentition, still you may not be able to do a mixed dentition because the dentition status is only primary teeth. In those instances, you have two dentition analysis which can be done on primary cast. So one is your Hookah analysis, which is nothing but your radiographic analysis. It's a radiographic method where you think of the proportional equation prediction method on primary teeth. The armamentarium which are required for your Hookah analysis, you need a dental cast of both the arches, Bowley gauge and a divider, a millimeter ruler, and you need a good periapical radiograph which has to be taken using a holder, or it could be taken with a bite wing radiograph taken properly. The proper X-ray has to be there where you are able to see the ideal mesiodistal width without any distortion. There should not be any overlap at the contact region of your teeth, contact area. So that should not be there. So the formula, most of us will know, x1 by x2 is equal to y1 by y2. x1 is the unerupted tooth width, which is seen on the, you are going to find out what will be the unerupted tooth width. So the unerupted tooth width on the X-ray will be the x2, whereas on the cast, you would have measured the erupted tooth width, and the same erected tooth width on the X-ray. So when you take a radiograph, you have to make sure that it is taken on a side which has a good, proper teeth without any caries and anything, so that you will be able to measure the unerupted tooth radiographically and the unerupted and the erupted tooth which is seen on the cast on that side itself. That will be the ideal way to do it. For example, if you are using your right quadrant, you should measure the mesiodistal width of the erupted tooth in the cast. That might be your 8.5, and the erupted tooth 8.5 has to be measured in the radiograph. So the proportion in which there is a distortion which we overcome, and based on the same way, if you want to calculate the mesiodistal width of the unerupted first premolar, that has to be calculated. So you will be estimating the mesiodistal width once it erupts into the oral cavity. So this is what a Fukuba analysis is. The other analysis, which is you can do it as your Boston University analysis, which was given by Janelli, and it is mainly done in the primary dentition. Once he gave it, it was done only on the mandibular arch. It cannot be done on your maxillary arch. But now they have proposed it after studies that it can be even applicable to your maxillary arches. So the armamentarium required or dental cast of both the arches should be there. Bowley gauge millimeter and a divider and a millimeter ruler has to be there. The principle behind is the sum of the width of your unerupted 3, 4, 5. That is your permanent canine and your first and second premolars is equal to the sum of the mesiodistal width of your primary canine plus 2 times the mesiodistal width of your first primary molars. So if this is the formula, they have given it, and they have found that there is greater chance of prediction. It is almost has a greater reliability. And this is the study they have done it on 2 radiographic methods that Vishara have compared it. And similarly, you have primary dentition analysis. This was done in another study by Dr. Sivakumar Nola sir et al. And they have done it, and they have proposed that this could be even applicable even to your maxillary dentition. That is, if you want to apply it for the maxillary cast, you have to mesiodistal width, you have to measure it. That is the primary canine and primary maxillary canine, but plus 2 times the primary maxillary first molar, 2 times the width. If you're going to calculate it, that will tell you what could be the required space for the unerupted canine and your first premolars. So once you have calculated it, then you will be able to identify how much of spacing and crowding. Then you have to go on to treatment planning, which is not going to be my part of your lecture. But if you want to have a minimal crowding between 1 to 3 mm off, then you have to wait and watch. If it is between little more than that, you can go in for a proximal slicing. Then little more you plan for an extraction followed with the space maintenance. If it is an excessive space discrepancy of around 10 millimeters on each side, then probably they suggest going for a serial extraction. But we are not going to go into the details of those things. The drawbacks of all these mixed dentation analysis is we never consider the profile of the patient. We just have the cast and we try to estimate the required space. We never consider the leeway space, how much space is available for each patient. And we don't consider the angulation of your lower incisors, that is the mandibular incisor mandibular plane angle. So that, because that plays a very important role. If the normal incisor mandibular plane angle, they suggest it has to be around 90 degrees. So if it is going to be 91 degrees, that means your arch perimeter is going to increase by 2 mm. For every 1 degree, there should be almost 2 times it is going to be, the increase is going to happen. And similarly, if the IMPA is going to reduce, the arch circumference is going to reduce drastically. So, but we don't consider those things. And similarly, the curve of speed. If you're going to have a deep curve of speed and if you want to straighten it, the arch length has to go increase. So we never consider those things when you're doing a mixed dentation analysis. We just consider only the cast and the clinical scenario, and we do it. That is the most important drawback of this, all these mixed dentation analysis. The take-home message related to mixed dentation analysis, or if you're going to have, it is purely dentition related. You have to make sure that it is only dentition related. We are not going to consider any of the patient's other facial profile and other things. MOIS is better for a population specific, and it is very easy, and it is based on your probability chart. Whereas Tanaka and Johnston is the most easy and the convenient one. And Hickson and Oldfather is most accurate, but when you're going to have a case on primary dentition, then you need to go either with your Fukuba or your Boston University analysis. So this completes my mixed dentition analysis lecture. And Dr. Sharad asked me to take specifically to talk about something on cephalometrics of what I do in my clinical practice or what I tell my PGs to do what here. Can I continue this thing, Sharad? Or you want to have any discussion related to mixed dentition analysis now? Or we will
I think you can. Jiva, I think you can continue with this. Kekada? Yeah, you can continue with this particular session. You can finish and then we can do the discussion together. Kekada, Jiva? Can you hear me? கேக்குதா ஜீவா? ஜீவா கேக்குதா? I'm not able to hear you, Jiva.
Is it audible now?
Yeah, I can hear you now. It was audible at that time. நீங்க ஆடிபிள்னு சொல்லும்போது கேக்குது நல்லா இருந்துச்சு. இப்ப மியூட்டடா இருக்கீங்க.
Okay, Sharad?
Yeah, we can hear you now. You can continue, okay. Jiva.
Right. So this is something which they asked me to talk about it, and which I'm going to talk now is my perception and what are the things which I do. And you have numerous cephalometric analysis. You have Steiner's, Down, Ricketts, Tweeds, Witts appraisal, McNamara, and Jefferson analysis. There are numerous analyses which are there, and we cannot be masters of all these analysis unless you're going to be the full-fledged orthodontist. But when you are dealing with patients, because you are seeing children from younger age and they come and see you, and most of the parents want you to do the maximum thing possible because you are the one who have been taking care of those children. So what I'm going to talk now is what I do or what I do in my private practice or what I tell my postgraduates to do. My cephalometric points. So these are some of the things which I try to do it on my patients who walk into my dental practice in the mixed dentition period. These are the things which I do. That is an anterior arc Jefferson analysis. The Jefferson analysis is one analysis which talks about the proportion of maxilla to the and mandible to the cranial base in a divine way. That is used. I'll be discussing on those things. So I'll be doing this anterior arc of Jefferson analysis. I'll do a vertical arc analysis of Jefferson analysis. I will look into the interincisor angle between your upper and lower incisors. So this interincisor angle will be shown even in your Steiner's and also in your Downs analysis. And I will do an IMPA, mainly the incisor mandibular plane angle. What is the relationship of your incisors on the mandibular plane? Or we will do the Tweed analysis. It's a triangular analysis. And most importantly, I will do airway analysis that is done according to McNamara. That is upper airway and lower airway. And then I will check the CVMA maturation, which is given by Bassett. I think Dr. Meera is going to talk about it, CVMI and all those things. But what I'm going to say is something what I do. These analysis will help me to find out what is possible for me to do and what things I should not do to the kid. I should not do something harm to the kid. They have come with a complaint. So what is possible? These things will help me to decide that these things can be done. These things should never be done. Like that, you have to do this. Cephalometric points will help you to decide on it. If you want to know much about cephalometrics, you have to go detail into it. But I'll be telling you how to do these part of these analysis and what are the things which you can infer based on doing these things. So when I'm doing my cephalometric points, usually the tracing paper, I will keep it in a horizontal format. This is how I place it. not in the vertical format, the usual way they usually orthodontics keep. So you will have to place it in a horizontal way, that the red outline shows you the horizontal way. This is how you have to place it when you want mainly to do the Jefferson's analysis. So going on to know what is Jefferson analysis. Jefferson analysis is something, a new analysis which has been derived from the what we have called as the Sassoni archaeal analysis. So this analysis was given by Sassoni in 1955, which was later modified by Besti Gerber. And later in 1996, Jefferson gave this what is called as the Jefferson cephalometric analysis. So he called that this analysis, it talks upon mainly by the concept of divine proportion. They say that each and every part of a body is based on this concept of divine proportion, that is 1.618:1 is the ratio. And this will be applicable to any part of the body from head to toe. If you're going to measure the total height to the total width, it has to be in this range, its proportion. If it is going to be in this proportion, then they say that the body is in a normal level. For example, if you're going to say that take the head of the patient or the facial part, it has to be, goes the upper face to the lower face, it has to be in 1.6. And within the mid face also, if you're going to put this one, the vertical relationship, it goes by this. So if you're going to have this type of proportion in your face, they say that it is going to be a divine proportion, which has a healthy face, which goes for a healthy individual. And horizontally, if you're going to measure the width here, the temple region, if it is going to be 1.618, then if you're going to measure the width in the eye level, it has to be in particular ratio. So this is how this analysis, it mainly based on this. What they propose is the divine proportion, that is the ratio of 1.618:1. So what they did, the Jefferson, he found a picture on a paper, newspaper model. This was a model's face, and this was the picture which was there. So he calculated the width and he found out that this face is the ideal face, which considers as that the proportion of 1.618:1 width. That is from top of the head to the menton point, and the lateral cheek border, the ratio was fine. So he considered this face is the ideal face. And if you're going to have this divine proportion, he said the face is going to be beautiful, the TMJ is going to be healthy, the patient is going to have a physiologic harmony, fertility, total health and wellness, everything is going to be fine. But if this proportion is not going to be there, then you land up in different type of face. That he called it as a long face. It can be a short face, or the one what we get is a ideal face. So in this way, he was searching for an individual who can have this perfect face. So he identified this patient who was a 21-year-old female patient who had a beautiful face and a good harmony was there. And he did a cephalometric measurement he did a ceph on this patient, and he developed this, what is called as the Jefferson analysis, which is, we call it as a archaeal analysis. So Jefferson analysis, he said that when you want to do analysis or cephalometric analysis, this analysis should tell us what is the anterior-posterior relationship of maxilla and mandible to the cranial base. Any cephalometrics should tell us the skeletal relationship with the cranial base, and also a vertical relationship with the, especially the mandible to the cranial base. So this has to be discussed, or it has to be told elaborately when you have to come to know it when you do this analysis. So only one such analysis was there, that is your McNamara analysis. So because if you take McNamara analysis, they usually measure the effective maxillary length, that is from a point called condyle to point A. They say that will be the length of the maxilla, and from condyle to point Pogonian, that will be your length of your mandible. And they say, and they will measure the vertical height from ANS to menton. So what McNamara would propose is, he would have proposed for norms that if you're going to have this much length of maxilla, the proportionate length of mandible should be this much for male and female. Individually, he would have given it. But what Jefferson did not believe in that is, it should not be individualistic. Any analysis should be based only on the divine proportion of their faces. So that is the only thing he was not able to accept McNamara, and gave this what we call as a Jefferson analysis. So for doing a Jefferson analysis, the armamentarium what you require is a lateral ceph, a tracing paper, X-ray viewer, a geometric box with good compass and a scale, and you need long scales to make a good lines. So I will be just showing you how to do it, because according to Jefferson, any analysis, it has to easy to be traceable, and based on the tracing, what you should be able to diagnose what the patient is, how far the patient is deviated from the normal one, and it should be efficient to tell that you have to do it in a faster rate. Only few things has to be done, and that has to tell you what is the face of the patient. And it should be universal. That is, it has to be applied for any individual, any races, irrespective of their sexes. And most important thing is, he said it should be based on biologic proportion. So all Jefferson analysis fulfill all these criteria, and the points which we have to mark it for doing a Jefferson archaeal analysis or Jefferson analysis is, you have a what we call, these are the points which has to be marked. You have a point called supraorbital. Supraorbital is nothing but the point where the roof of the orbit merges with the lateral body of the orbit. I'll be showing you how to trace that point in a cephalometric. Next is your sella inferior. It is the lowermost point of the internal contour of the sella turcica. Usually the sella point, we mark it on the midline of the sella turcica, whereas for this Jefferson analysis, we have to mark sella inferior, that will be on the lower border, and anterior nasal spine, that is the anterior tip of the premaxilla and the mid-sagittal plane, and posterior nasal spine, it will be on the point, on the posterior point on the maxillary bony plate, and this will be almost at the tip of your pterygomaxillary fissure. Next, you should do the constructed gonion. So you have to make a line, you draw a tangent parallel to the ramal plane, another line parallel to the mandibular plane, and these two planes, when they intersect at the gonion point, we call that as the constructed gonion. So these are the 5 points which we mark on the cephalometrics for doing Jefferson analysis. So if you're going to see, this is the point which is going to be there, and I have got a small video. I think I hope this you will be able to hear it. This is how it has to be done. Is it audible? Sharad, is it able to hear it?
No.
Video sound is not coming.
You can narrate, no issues.
Sir?
Because it is not audible much.
Okay, sir.
Dr. Jiva, your video is not audible. We can hear you talking. You can do
Okay, if that is not audible, I'll be. So
You explain it.
Yeah. Inferior most point, that is the point where you mark it as sella inferior. Inferior, that's the point. Nasal spine is the most anterior part of your premaxilla, and the posterior nasal spine is going to be that. Another point is going to be the pogonion, menton, and then consider point. That is the occlusal contact area. Second premolars and the contact between your mandibular or the maxillary molar, six-year molars has to be marked. That these 2 points will be useful to plane the, that is the occlusal plane. Then you mark the line on the tangent on the posterior border of the ramus and the lower border of the ramus. That will give you the points. So next, once you have marked these points, that is, you would have marked supraorbital, you would have marked sella inferior, you would have marked out nasion. Then we will be constructing 4 planes. We call those planes, one is called the cranial plane, which was ideally called as a parallel plane in the original Sassoni analysis. So cranial plane is a line drawn from supraorbital to sella inferior, and that line has to extend posteriorly. That is why I told you need to have a long scale. And the the tracing paper has to be placed on the other way. You have to place it in a rectangular format. Next, if you're going to connect the ANS to the posterior nasal spine, that we call it, that is your palatal plane, a line drawn connecting your ANS and PNS, and that line has to go posteriorly. And for occlusal plane, usually there is always they feel that you have to mark the intersection of your permanent molars and the intersection of your premolars or your primary molars. Some people try to mark the intersection of the molars, and some people try to mark the intersection of your incisors. That is not the right occlusal plane. An occlusal plane has to be marked only with the intersection of your molars and the intersection of your primary molars or your premolars. 2 points has to be marked, and a line connecting it going posteriorly towards the left end of your tracing sheet. Next is your mandibular plane. That has to be a line connecting the menton and the constructed gonion, and that is how the plane has to go for it. So once you've done all these planes, so this is how it is done. Sella orbita, superior orbital fissure, sella inferior, that is the superficial plane. It is a cranial plane. So that is the plane which we are going to study about the relationship with the maxillary plane, occlusal plane, and your mandibular plane. So these are the 4 planes. And if you want to mark it, this is how it has to be done. Okay. So the first point you need to mark is the SOR, that is the supraorbital fissure. It is the intersection of the roof of the orbit and the lateral border of the orbit. SOR has to be marked, and then we need to mark the sella inferior, that is the inferior most point on the lowest contour of your sella turcica. We call it as sella SI. So connecting these 2 points in the plane, the line has to go as much as posteriorly. We call that as your cranial plane. This is the first plane which we try to construct it. Next plane is going to be your palatal plane. The second plane is going to be marking a anterior palatal spine, the posterior palatal spine. And connecting these 2 points of APS and PPS and the line going behind, intersecting the previous cranial plane, we call it as the palatal plane. The third plane, what we are going to construct is your occlusal plane. I told you, you have to mark the point of intersection between your permanent molars and your primary molars. Sometimes we mark it in the incisors. That is not the right way. So we are talking about occlusal plane. So we have to mark it only on your intersection of molars and the intersection of primary molars or your premolars. So you have to make 2 consecutive points, and you connect these 2 points, and these 2 points, when they go run posteriorly and intersect already done 2 planes, that is your palatal and your cranial plane. So this is how it has to go back. And the last plane what we have to mark is your mandibular plane. It is a plane connecting the menton to that. So for that you need to do the construction of ramal plane, and then you do the lower mandibular ramal plane has to be marked. These 2 points, they get intersect, that is your constructed gonion. So that constructed gonion point is the one which is very important. From there, connecting the menton will be your mandibular plane. So this is what your mandibular plane is. So these are the 4 planes which we need to mark it: the cranial plane, palatal plane, occlusal plane, and your mandibular plane. So once we have done all these planes, then what we need to do is to mark the point. That is, you have to construct the point what we call as the center wound. For that, you have to mark the intersection of the 4 planes. Wherever you have to try to make a line which connects all the 4 lines at the point of intersection, but at the point of intersection, all the planes, and you will have numerous lines, vertical lines connecting all these 4 planes. And you have to see which is the smallest line. And in that smallest line, the midpoint of that line, we call it as a center O. So this is the point which we need to identify it. So for that, all the 4 planes has to be connected, and at the point of intersection, you try to draw vertical lines, and the smallest vertical line, the midpoint of that smallest vertical point is called as the center O. And with that point, we will try to construct an arc, which I'll tell you in the next slide. So how to do the center O point is that, so this is how you need to do it off. So you see this 3 planes and all the 4 planes, they try to coincide and they get intersected at the back portion of your tracing paper. So now you need to mark these vertical lines one by one. So connecting all the 4 planes, that is your cranial plane, palatal plane, occlusal plane, and your mandibular plane. So you need to make just vertical lines which runs across it. And you know how to, that has to go on both sides. So one side you will have a long lines, and the other side also you will have long lines. So in between that, you might have the smallest line. That is the line which you have to make sure, and the midpoint of that line you have the point what is called as the constructed O point. So this is what the first point which you constructed when you are doing this Jefferson analysis. So once you have done with Jefferson's point construction of O point, then we have to just construct 3 arcs. The first arc, we call it as the anterior arc. So what is this anterior arc? Is the anterior arc is the one which is going to tell about the relationship of the cranial base to the maxilla and the mandible. For an ideal patient, what we saw in the 24-year-old female, if you're going to make an anterior arc, it has to be from point O to the point Nascion. Point Nascion will be marked as the junction of your frontal bone with the nasal bone. That point is your Nascion. So if you're going to make an anterior arc with the diameter, with the center point O and your Nascion, ideally that arc has to go, if it will start from the Nascion, and it has to go closer to your ANS and closer to your Pogonion. If you're going to have an ideal arc and the face ANS is just 2 millimeter behind, and the Pogonion is, if it is going to be just 2 millimeter behind the arc, we call it as an ideal arc. And this arc was seen on that 21-year-old female patient. So this is how we have to construct an arc. So here you see the red point and the back portion, that is your constructed O point, and align the red arc which is drawn with the diameter O to N. And that we call it as an anterior arc, which gives it runs closer to ANS and closer to Pogonion. So this is, we call it as an anterior arc. So how to do this arc? Then you have to take your compass. You have to make sure the pencil is slightly longer than the normal way you use it when you are doing your school times. So you have to make sure that you have to keep it a longer one. The pencil has to be nicely long. Keep the point of compass on the O constructed point. And then the pencil part has to go onto the Nascion. And from there, you need to construct an arc which runs, that is the Nascion point. So from there, you will be constructing an anterior arc. So that we call is your anterior arc. So ideally, an anterior arc, if you see, it has to be that ANS has to be 1 or 2 millimeters behind anterior arc. Pogonion has to be slightly 2 millimeter behind anterior arc. And even your incisal edge of maxillary incisal edge, if it is going to be on the arc, it is in correct angulation. So these are some of the things which you will check. So an anterior arc, ANS and Pogonion, it should be like. So ultimately, when you do an arc, the maxilla and mandible, if it is going to be online, we call it as a type 1. So here we discuss what we call as a type 1. Type 1 is related to skeletal type 1. And this is not to be confirmed. I mean, instead of you have a class 1, because when we say class 1 skeletal relationship, we obviously get confused, because when you talk about class 1, we always remember class 1 molar and class 2 molar relationships. So here the skeletal relationship, he would have discussed in a different way. He would have said it is a type 1 relationship, type 1 skeletal relationship. That means in the anterior arc, the maxilla and the Pogonion point will be just anterior. In the anterior arc, it will be just 1 or 2 millimeters behind it. So by this, he has given a classification where you have 9 types of skeletal problems. One is where the anterior arc ANS is on the anterior arc and the Pugonian is always there. Type 2A. 2 is always related to one classification where your maxilla is forwardly placed. So 2A is where the ANS is ahead of the anterior arc, whereas the Pugonian is on the anterior arc. Whereas type 2B is where the ANS is on the anterior arc, whereas the Pugonian is well behind the anterior arc. 2C is a combination of both. That is, maxilla is also forwardly placed. The mandibles also is placed very retrusively. That is what type 2C. So when it comes to type 3, that is a type 3 skeletal word. Always 3 relates to a skeletal. Here, when 3A is where the Pugonian is on the arc, whereas the maxilla is retrusively placed. That means an ideal class 3. In type 3B, the ANS is on the arc, whereas the Pugonian is slightly forwardly placed. Whereas type 3C is a combination where mandible is forwardly placed. That is, the Pugonian is well above the arc and the ANS point is well behind the arc. So this is what the classification. But sometimes when you draw it, you might be landing up in a situation where both ANS and the Pugonian will be very much well behind your anterior arc. We call that as a biskeletal retrognatism. And if both the points are in front of your arc, then you call it as a biskeletal prognatism. So this is how Jefferson classified the skeletal base of skeletal classifications. So this is the 9 type of skeletal classification according to Jefferson you can encounter. Any patient has to fall within these 9 categories. They cannot go beyond it. So whoever comes has to be fit into any of these 9 categories. Right. So once he has done it, then he analyzes the first done, they will analyze the anterior-posterior relationship of maxilla and mandible to the cranial base. The second, he will analyze is the vertical relationship. So they do the second arc. We call it as the age 4 vertical arc. So age 4 vertical arc is nothing but it is going to relate that the vertical height. So what a divine proportion should face have is the distance between your ANS to your supraorbital, what we mark, should be equivalent to ANS and menton when the patient is at 4 years of age. That means this height should be equivalent to this lower facial height when the patient is at 4 years. But after that, every year, the vertical height will keep increasing by 0.75 millimeters. That means it increases from 4 till 14. That means 0.75 into 14, you have to calculate it. So vertical height keep increasing by 0.75 millimeter per year. This is what Jefferson has said. So we will see how to mark the supraorbital or the vertical arc. So vertical arc, the first thing what you need to mark is your ANS supraorbital. That will be your upper facial height. And the same ANS, if you're going to mark that, that will be the vertical height at the age of 4. So the menton has to lie exactly there. If the menton is lying above and the arc is going beyond the menton point, that means they have a lower facial height. It is a short face. And if this part is longer, then we call it as a long face. So how to construct that point is, first you need to height. For construction of vertical arc, you have to first mark the ANS. You have to paste on the ANS, and the other point, the pencil has to be on the supraorbital point, which we marked there. That is the intersection of the roof of the orbit and the lateral wall of the orbit. That will have the vertical height. So make an arc there or measure that point. And the same measurement, if we are going to put it on the mandible, that arc, we call it as the vertical arc. And this has to be equal when the patient is at 4 years of age. So you can, if you want to measure it also, you can measure it. But if you're going to have, next is you have to mark the age 18 arc. That is, the patient is at 4 years. So we already calculated that is 0.75 into 14 years. It is going to be almost at 10 millimeters. So you have to measure this ANS to supraorbital, make a menton first arc, and you have to measure that distance, how much? Probably if it is going to be 9 point or 5.8, then you need to add 10 millimeters to it and make another arc that will be your age 18 arc. That is the vertical height, what should be present for that patient, that divine proportion at that age of 18. So it will be just another 10 millimeter because it increases 0.75 millimeters per year. So once you have done this age 4 arc and your age 18 arc, then we need to do the specific age specific arc. For example, if you're going to have a patient by 10 years, already you know for age 4 you would have marked a point. So from then you need to calculate another 6 more years. That means 6 into 0.75. You have to multiply it. You have to just add that much millimeter. Probably it might be another 3 millimeter. So if you're going to have a patient of 12 years, so it will be a 6 millimeter has to be added with the distance from ANS to Menton or ANS to SOR. Then if you're going to make that point, that is the age specific arc. So at the age specific arc, for that point, the Menton should exactly lie on the age specific arc. If it is not going to be there, then based on that, you classify the vertical one. If it is going to be on the Menton, if it is going to be on the age specific arc, then you consider that vertical height as normal. And if it is going to be short, the patient is having a short face. If it is going to be long, then it is going to be a long face. So these three types can come with any of the above 9 types. Then you get multiple malocclusion combinations. Type 1 normal, type 1 short, it can be type 1 long, like that it goes on. So whatever the combinations that you have to identify the skeletal anterior-posterior component, then you will find out what is the skeletal vertical problem, what the child is asking. So this is the age-specific arc, what we're going to do it. At age 12. At age 12. So you just add up that point of 0.75 millimeters to the already known width of your ANS to supraorbital, and you need to add that, and using that, and if you're going to make that arc, and that we call it as the age specific arc, which we need to do it for individual patient and analyze whether they have a normal vertical height, they have a short vertical height, or they have a very long vertical height. This is how it goes off. Your age specific arc has to be done. So according to Jefferson skeletal arcal analysis, these are the malocclusion problem which we will be finding out. A skeletal type 1, a skeletal BR, a biskeletal retrognathism, or a skeletal prognathism, or a skeletal type 2A, where the maxilla is forwardly placed and mandible is at the arc, anterior arc, or skeletal type 2B, skeletal type 2C. And then comes your type 3A, type 3B, and your type 3C. After this, the vertical one, it can be any of the three. It can be a normal one, a short face, or a long face. So the combinations, if you are going to make, probably you might land up in around 27 types of occlusions. So that is how it goes. So this is what I do for my patients who walks into my dental practice, this Jefferson analysis, anterior arc, and I do the vertical arc and find out whether my patient, they have a sufficient anteroposterior relationship, what is the problem, which part of the maxilla, or which part of the face part is it having a problem, whether it is a maxilla or it is a mandible, how it is related to the cranial base. The next, what I do to my patients, I'll try to find out what is the interincisal angle. This is what I do it. So if you're going to have a normal incisor angle, this interincisal angle will be a part of both Steiner and Downs analysis. So the angle can be around 130 degrees. And based on that, there are three types of divisions are there. If you're going to have a type division 1, which means that the interincisal angle is around 120 to 140 degrees. It is almost like a normal interincisal angle relationship. A division 2 is a more of a 140 to 160 degree. That means it's more of a obtuse one. They have a more of a flat face. And division 3 is a 100 or 120 degrees where they have a very acute angulation of your incisors. So what these things will tell us is, it will tell us whether you have to do any things here. You will be choosing patients to do serial extraction. You will be thinking because of high amount of crowding, you will try to do what could be the possible. You have already done your analysis. You have a lot of space issues. Because analysis, they never consider the angulation of your incisors. But here we have to see it on the radiographs. For example, if you're going to have a patient like this, where the relationship is going to be almost normal. It might be around 120 or it might be in between 130 or less than 140. If the patient interincisal angle is right. But if the patient is going to have crowding, and if you're going to go for an extraction of multiple teeth, and if you're going to make the incisors more and more obtuse, then they might have a flat face. So that is what division 1. You have to be very careful. So if you're going to have in these situations, what I prefer to do is, instead of going for extraction, you have to think of proximal slicing, because we want only minor tilt of your incisors. So division 1 is where it is almost an ideal interincisal angle. Another division 2, where you have an obtuse incisor angle, because it is more flatter. And if you're going to have a more flat profile for a patient, the thing what you have to do, whether you are treating the malocclusion is not a problem, but you should not create any untoward harmness to the patient. That means you need to avoid any extractions. If you're going to plan for any extraction without proper diagnosis and treatment plan, then you might still flatten the face, and the nasolabial angle and all those things are going to change. So division 2 is a condition where they have a more of an obtuse one, where in this patient, if you are going to even procline the incisors, they might have a good profile. And usually when patients have division 2, they usually have a very lower facial height. So bite opening and proclination of incisors, you can think about it. The third division is your acute relationship, where the angulation is almost 100 to 180 degrees. So in these situations, we need to retract the incisors and bring it to an optimum decision. So here we can think of any extraction along with your space maintenance. So the idea of this interincisal angle will tell you whether what you should not do to a particular patient. That you should not create more harmness by just going on with the mixed dentation analysis, because there is a severe crowding. And if they're going to have an interincisal angle in the division 2, and if you're going to extract it and the incisors go more going to retrocline, and you're going to iatrogenically cause a lot of damages to the patient. So you need to avoid. So cephalometrics for a pediatric point of view, it is mainly to have some knowledge to make sure that whatever you are, whether you are able to treat the malocclusion or not, that is secondary. But without knowing these things, don't create untoward iatrogenic damages to the patient. And next, I go on for your tweaks analysis. That is your, most of us will know that is it's a triangular analysis which consists of 3 planes. That is your Frankfurt horizontal plane, that is your line connecting your orbital to your chorion, and your mandibular plane, it is a line connecting the menton to the gonion. Here the gonion is not a constructed gonion, it is the skeletal gonion point. And next is your plane 3, which is your line connecting to the long axis of your lower incisors. And when these 3 lines are connected, you obviously develop what we call is a triangle, which is what the Tweeds triangular analysis. And any triangle should have an angulation of almost equivalent to 180 degrees. So what they have proposed is the Frankfurt mandibular plane angle. That is an angle here. The FMA angle has to be around 25 for a normal individual. If the angle is short, that means they have a short face. And if the angle is wider, they have a long face. And similarly, the Frankfurt incisor mandibular angle, it is another most important angle which I do consider is, that is because the incisor mandibular plane angle, they say that it has to be almost 90 degrees. But sometimes even 95 to 100 is acceptable. But if it is well beyond, if it is 110, 108, if it is more, that means that those patients, the mandibular incisor has to be retracted. So that has to be in your mind when you want to plan any mixed dentation analysis and you want to plan treatment. So this IMPA angle of Tweeds analysis, which gives me some knowledge to assess what type of growth the patient is having, and along with that, mainly it will tell me to know what is the incisor mandibular plane angle, what is the relationship of incisor to the mandibular plane. And most important thing what I do is going in for an airway analysis, because nowadays the myofunctional therapy has been a great impact on pediatric orthodontics, and you go for myofunctional therapy, myo braces, a lot of things are all functional analysis. So when you want to do a functional analysis in a mixed dentition, if you're going to take a cephalometrics, airway analysis is very much important. That comes with McNamara analysis. So you have 2 airway analysis. We call it as an upper airway and your lower airway analysis. The upper airway is nothing but you have to mark the soft palate, that is the inferior, the arc, the red arc, that will be your soft palate, because the soft palate arc will be in continuation from your maxillary palatal plane. The PNS will be there. From there, if you're going to, you will have the soft tissue shadow, and if you're going to mark that arc, it is going to be your palatal, that is your soft plate, soft palate, the superior point of your soft, that arc will be there. And posterior to it, you will have the adenoids. And if you're going to have an adenoids there, that will, and you mark the border of it, that will be the most anterior point of that line, and the distance between these 2 points we calculate, and we could tell that is your upper airway analysis. So most of the children who walk into the dental practice, you have an incompetent lip, they will have a mouth breathing problems and all those things. So without analyzing the CEF, without knowing about their airway and getting an opinion from ENT, don't try to go ahead with management of these mouth breathing problems. So you have to know what is this upper airway. And this is another kid of one patient who walked in my dental practice. You see that the patient, the parent, if you're going to ask them, they breathe, they say they will be fine. They are not breathing through the mouth, but he has an anterior open bite, incompetent lip, and I just referred him for a cephalogrammet. And if you see, it's just only 2 millimeters, the border of, so much of inflammation is there, and the upper airway is almost completely blocked. And he has compensated that by having a very wider lower airway. So this has to be evaluated. So for a normal upper airway, it has to be around 15 to 20 millimeters. That you need to measure it from the, that is the line, the anterior most point on the pharyngeal wall, posterior pharyngeal wall, that is near your adenoids. From there to the soft palate, that point will give you the upper airway analysis. The next, you have to go in for your lower airway. For lower airway analysis, you have to find that the intersection of the posterior wall of the tongue on the lower border of the mandible, that will be a point. So the tongue will posteriorly, it will be overlapping on the mandibular ramal plane. That point, from that point, a horizontal line which connects the posterior wall of your pharynx, that will give you the posterior airway. That is your lower airway will be that. So the lower airway has to be around 11 to 14 millimeters. Upper airway, it means that upper airway constriction is a severe problem. When you have a lower airway constriction, it doesn't mean that there is a big problem. But if your lower airway is widened, that is, you have an increased lower airway, it means that the tongue posture is more forwardly placed. They keep the tongue forwardly placed. As a result, the posterior or the lower airway is wide across. So you have to find out what is the reason for them to keep the tongue very anteriorly. And this analysis will tell us what is the relationship of these airways. So McNamara analysis, upper airway and lower airway has to be done. And I usually do it on all my mixed dentition patients, especially if I'm going to go for myofunctional therapy. Once this is done, and this is the most important part, is your cervical vertebrae maturation stages. I don't think I will be able to discuss much very detail about it, but this everyone has to learn about it. It is a very simple maturation analysis which can be done on the lattice program. Only you need to see the borders of the second vertebrae, the third vertebrae, and your fourth vertebrae. So there are 6 stages. This was given by a person called Bassetti in the year 1995. And there are 6 stages, CS1 to CSN6. So if you see, only these 3 vertebrae will be considered. The first CS1, where if you see the lower border of all the 3 vertebrae, that is the second one, third one, they are all flat. In CS2, there is a mild curvature on the second vertebrae, whereas the lower third and the lower fourth one, they have a flat surface. And if you see, it is almost trapezoidal in shape, and this will try to become more as a rectangular or more like a square as you go in stage by stage. In stage 3, you will see a slight curvature or concavity, they call it as on the cervical vertebrae 3. And when it comes to stage 4, you will see a concavity on the fourth vertebrae. And if you see, the trapezoidal form keeps changing. And this has been analyzed by Bassetti, and they have proposed this, analyzing this and correlating with the skeletal growth. What they usually say is, I think Dr. Mira has told you about this cervical vertebrae maturation, and I think he will be talking much more in detail. But this what I do in my practice. I mark the cervical way maturations. So if you are going to be on the CS1 and 2, that is the stage where the work has to be done mostly on the maxilla, whatever the work we do on the maxilla. If you want to bring the maxilla forward, that is prognathism maxilla, or if you want to transversely expand the maxilla, the results what you get will be more when the same procedure is done on the later stages. And similarly, when the patient is in CSS 1 and 2, and if you want to try to bring the mandible forward, the effect is going to be very less. So if you take CS1 and 2, what you will see that a transverse expansion or a face mask therapy, that is trying to work on the maxilla, bringing it forward, class 3 malocclusions, it has to be attended early as per this CSPM stages. So if you're going to target these patients, you have to check those things and then plan your treatment. For us, if the patient is on CVM 3 and 4, that is the stage they have a maxillary, the mandibular growth, because they are nearing the puberty growth spurt. So that is the stage where if you want to go ahead, you can try to bring the mandible forward by doing a fin block. So this is something which you can take as a, keep it in your mind as a take-home message. If you want to work on the maxilla and the cervical pettimature stages should be early. That should be, it has to be in 1 and 2. You get maximum effect. And if you want to work on the mandible, you wait when the patient enters the stage 3 or 4, where if you want to lengthen the mandible, that you want to bring the twin block using I'm going to increase the length of the mandible. You wait when the patient enters 3 and 4. If you're going to give a twin block when the patient is in 1 and 2, there will not be sufficient. The effect might be there, but that might not be a stable one. And the peak effect, the patient has to wear it for a longer time. That is what the Dr. Rapira was telling, the worn-out appearance. The patient will get fatigued. By the time when they want to wear it, they might not be able to do it. So this is what I do as cephalometrics for my patients in my private practice, and what I ask my postgraduates to do few things. So this completes my lecture, and thank you for your patient listening. And if you have any doubts regarding it, and if I know it, I'll be able to explain to you. Thank you.
Thank you, Jiva. Kekida?
Thank you, sir. Thank you.
Yeah. Thank you, Jiva, for that extensive explanation about everything what a postgraduate student might want to know. I just want to know a few things which have been asked from some of the PGs actually. Okay. In Boston University approach, in case a second primary molar is lost or canine is lost, substitute teeth vachu panalama. Can we have a substitute tooth?
Second primary molar is lost.
Yeah, in second primary. The question asked is like that. Either the second primary molar or canine is lost. I think in general, in if that particular tooth is lost, is there anything like this thing?
If the second primary molar is lost, still you have in Boston University, they say that you have to take only the mesiodistal width of your first primary molars.
Okay.
For example, if the first primary molar is lost in this side, probably you can take the contralateral side and measure it, and then you can apply it on the other side, because usually there might not be any mesiodistal with the variations. But if your second primary molar is lost, Boston University will still be applicable, because you have the first primary molar. You know the mesiodistal width of it. You can just add 2 times that one and canine. But if your canine is lost, then on that side, if it is lost, try to go for the opposite side.
Okay.
If both sides are lost, then it is difficult to do it.
Okay. I think some of the questions are all very similar to that. Which model analysis should be used when there is only lower central incisor in the permanent teeth which are present, whereas lower laterals are primary? Lower centrals are permanent, lower laterals are primary. I think based on individual conditions in each PG's life, I think there are some questions. I'll ask you another question. If upper laterals are unerupted, and is it still appropriate to use measure from the distal of primary lateral without relying on the radiograph?
No,
I think, yeah, I think the questions are all based on the specific tooth irka illaya. If the tooth is not there, what should you do?
Okay. So this, if it is going to be from exam point of view, to be on a safer side, if you say only your mandibular central incisors have been erupted, preferably you have to go, you cannot do any of your mixed dentition analysis. As per the principles of mixed dentition analysis, you cannot do it. So better you can go in for a Hukaba or your Boston University analysis. But if your external is going to start asking you what is there any method to do it? There is no specific method, but if you want to do it, then again, what you have to do is you have to take a radiograph, apply Hukaba for the mesiodistal width of your lateral, find out what could be the proportionate difference, apply it, calculate it, and do it out. But these things are not given everywhere. It's not given anywhere. But if they are going to ask you, is there any possibility to do? Then you can say that if one tooth is lost, for example, if the mandibular lateral is not erupted and if you still want to do a mixed dentition, then you need to take a radiograph for the lower anterior region. You know the erupted mandibular central incisor width that will be available in the cast, that will all be available in your X-ray. So you need to apply a Hukaba analysis for estimate to find out what could be the mesiodistal width of your unerupted lateral incisor. Probability you have to find out. Then you can add it and try to do it. The same way you can do it for maxillary lateral. But these things are not given anywhere in the literature. If they are going to ask you specifically, is there any possibility, not out of possibilities, then you can tell these things can be done, but it is not proven or evidence-based.
There's one question by Dr. Harshita. Do you want to ask that question or do you want me to read it, Dr. Harshita? You want to unmute yourself and show yourself and you want to ask a question? Dr. Harshita? Regarding Jefferson's analysis, sir spoke about 2 arcs. What does the third arc indicate and what is its significance?
Third arc. Third arc is the age 18 arc. The third arc is the age 18 arc because you draw the age 4 arc. Age 4 arc is the distance of ANS to the SOR. So which has to be equivalent to the menton at 4 years of age. But every year, the vertical height increases by 0.75 millimeters. So if you're going to multiply 0.75 into 14, it will be around 10 mm, 10.25. So you need to add 10 mm to that and make another arc, which will be your age 18 arc. So it can be done. So if you're going to have a patient between anything between 4 years and 18 years, any age, you have to identify what is their age. You have to multiply that 0.75 to it, add to the already what is their age 4 arc. And if you're going to make an arc, that will be your age specific arc. So probably, I think I didn't explain that age 18 arc. I explained it only in the second part. So that is the one thing, age 4 arc. If you're going to, what is that measurement? To that, if you're going to add 10 millimeter, that will be your age 18 arc. Am I clear, Sharath? You just find out whether she has been cleared by this.
Yeah, I think I understood what you have mentioned. If she has a question, let her type it and I'll read that for you. There are 2 questions again, Jiva. It's based on I can definitely tell that it's based on a PG's exam point of view or based on the clinical cases they have. After model analysis, if there is space excess available, right? Or what is the treatment plan according to the amount of millimeter available? Any criteria? Because I think teachers will say space is available. Why do you want to put a space maintainer? Or why do you even want to maintain that space? Okay. I want to club up with one more question as similar to that. Is there any criteria for planning space regainers? Right? When you want to put a space regainer, because the space measurement, whatever you've done, has said there is a space loss. So is there anything like so many millimeters of space loss is there? You have this kind of treatment plan. Like you say, 5 millimeter space loss, first premolar extraction, second premolar extraction, space regainers. They want to know. I think this all looks like typical postgraduate questions asked by their teachers. Maybe from my point of view, I think there are no direct textbook answers for that. But if you can share your experience based on how you do it as space regainers, what you do when there is a space available. Will you still agree that even if there is a space available, should we want to go for the space maintainer? So your take on that.
The thing what you have to analyze is, see, space, if you're going to do a space maintainer alone, and if you're not going to concentrate on space management. If you're going to have a patient where you're going to do a space management, then just measuring, doing a mixed dentation analysis, finding out what is the space available, they land up in excess space, so just leaving like that is not right. Maybe, probably it might be for a discussion part, but then you have to do a space management part where you have to check other components. You have to see what is their occlusion. Most important thing which we don't consider is the intercuspation, whether there is a class 1 molar relationship or a class 2 molar relationship, whether the mandibular molars and the maxillary molars, they will not migrate. Is there a stop? They have a perfect stop. If you are able to find out a perfect stop is there and you have a land up in excess space, definitely you no need to go in for a space management. You don't need to give a space maintenance. But if you are unfortunately the occlusion is in end on, there is no perfect intercuspation, then definitely you have to give a space maintainer even though there is a excess space. So that has to be considered. Apart from just only your teeth dimensions and other things, the intercuspation on both sides has to be evaluated. That is very much important. And regarding space regainer, and it depends upon the clinical situation, because space regainer is not so easy. It can be done. You have different types of space regainers, but certain regainers are not quite very easily, you cannot do it. And if you're going to ask me, but if this much millimeter of space is lost, what type of space maintainer I can do? You cannot judge like that, because each and every specific situation, you have to choose a space regainer and do it. Pertaining to the dentition status, if it is in the primary dentition, what you can do it. If it is in the mixed dentition, what type of space regainer. It is not a simple way, just you do some appliances with springs and do it off, because you need to have a wide knowledge. You have space maintenance, which has to be done along with partial orthodontic treatment also to gain support of your lower front teeth. You want to push your mandibular molars back. It is not so easy. If you can give a lip bumper which can push your mandibular molars on both sides, but you should have a relationship. What is the relationship for your upper teeth and lower teeth? Whether you can give a mandibular lip bumper can be placed, or you need to have some fixed orthodontic treatment along with the space maintainers, then a space regainer, a partial regainer. You have different types of appliances. So you cannot specifically say that this type of space management for this type of condition. You cannot be very specific, but it is a difficult part.
Yeah. You have one more question. This has come from the YouTube participants over there. If there is crowding when you are calculating the mesiodistal width when you're doing the mixed dentition analysis, should we alleviate the crowding? How do we alleviate the crowding?
Definitely you need to do it. That is why I say you have to individually measure the teeth on each side. Sometimes there might be a mild variation could be also there. So never take one tooth and do it up unless you don't have the tooth. So you have to minimally measure it. If you want to alleviate crowding from the midline, for example, we have measured 3.1, the width is around 5.5 millimeters. And we have measured 3.2, that is around 6.5 millimeters. So what you need to do it, you can either add up both the things combined with, measure it on a scale, or you can measure it on a brass wire, put it from the midline to the lateral aspect, mark it there. That is how you can alleviate it. Or individually, you can mark from the midline, mesiodistal width, 5.5 millimeters. From there, again, add another 6.5 millimeters. That might land up on the canine area. So mark that line. That will be your L2 line. So you have to alleviate. Without alleviating, if you are going to do the mixed dentation analysis, is wrong. There is no point in doing it. You have to alleviate it. Then what is available? Because the lower anteriors, you have leeway space at the back by which you can be compensated. But here, lower anteriors, it cannot be done unless you change the angulation of your lower incisors and upper incisors. So if you change the angulation, you increase your arch perimeter. If you reduce it, you decrease your arch perimeter. So you have to alleviate crowding before you go on for the next stage. The L2 line has to be marked only after alleviation of your crowding, both for axilla and for the mandible.
One last question, Jiva. What is the shorter method of Moyer's mixed dentition analysis, which you had asked? I think
it is the Tanaka-Johnston analysis.
Yeah.
Tanaka-Johnston is nothing but is a short way. Actually, Tanaka-Johnston, what they did, they replicated Moyer's on a different population, and they gave the same probability one, and they found out that almost both were equivalent. But they don't want to give the probability chart. They found out a new formula, and they gave what is called as your their Tanaka-Johnston analysis. That we call it as the shorter method of bias analysis.
I think all the answers which you gave actually reminded me of RPG days when Vishwakumar sir, who was a master of space maintenance. Sir's LD was on space maintenance, and sir used to ask us to check whether your check molar occlusion has come in, whether it is whether there is a contraindication for class 2 and class 3, which was there only in sir's LD, and removable space maintenance. So it was definitely a good reminder for me. Thank you, Jiva, for sharing your expertise. I know I literally forced you into accepting this invitation. Every program which has been organized either from ADE or from the Department of KSR, IDSR, I think you have been a part of it, and thank you for accepting this invitation. If Shivakumar sir is around, can I request Shivakumar sir? Yes, he's here. So our teacher is also here. Sir, anything which you want to talk about our space maintainer life in Meenakshi Ammal Dental College? All the questions asked were very similar to what you taught us 20 years before. And still, I think the same doubts are existing in our students' life, because it's based on the questions which are asked by the teachers on a routine basis. Yes. And I would also request you to hand over our certificate of appreciation to Dr. Jiva. You can add a few words and then you can pass on the certificate.
Nothing. It is as usual. Nice presentation by Jiva.
Thank you, sir.
Right from the PG days, he is doing good presentations. So I hope we will continue the same thing.
Thank you, Sharad, for giving me this opportunity.
Just give me 1 second. I'm trying to share this thing. Yeah, can you see that, Jiva? Is it visible?
No.
Not yet.
Give me a second. Somebody else is trying to stop screen sharing. I'll try to do. Is it visible? Not yet.
No, Sharad, no problem.
Yeah.
Now it's visible.
Yes. No problem. Only thing is, we are 2 or 3 of us are sitting as hosts together.
Okay. Now again you have to share.
Yes. Thank you.
Yeah.
I'm happy to hand over the token of appreciation from KSR DSR to Dr. Jivarathan and his wonderful presentation.
Thank you, sir.
Whatever topic we gave, we made him to modify also, sir, because we knew that some doubts will be there, cephalometrics a little bit. So we kind of pushed him to do this thing. Thank you, Jiva. Thank you for.
Thank you, sir. Thank you, sir.
Yeah. Thank you. Before we all leave, I know most of them have started leaving. Whoever's around, can you switch on your cameras for just one small picture? We would like to have a picture. Is anybody around? Or everybody? Yeah, some of you are there. Thank you. Harshita, I think we missed you when you were supposed to ask the question. I think you just left. Yeah. I think our team also can join. If Farzan, is anybody in Meenakshi there? If somebody is there.
Yeah, announced it half an hour back so that they would have been ready.
Yes, sir. That's fine, sir. Like we can still. Yeah, I think some of them have managed to open. Yeah. We'll take a screenshot of this once, please. Yes. Thank you so much, sir. Thank you.
Right.
Thank you, everyone.
Yes, sir. So we'll have a small 15 minutes quick lunch break, and then we'll start at 2 because we told Meera to come back again at 2 o'clock.
Okay.
So, yeah. Thank you. Thank you.
Thank you, sir.